So, hello and good evening, everybody. Welcome to DBMCI MDS, the INICET May 2025 exam analysis. I am Dr. Himani Joshi. And before we begin anything, guys, the most important thing is two major exams are over. You guys have worked very hard. You guys have given the exam. It's not the time to think of what next today. Those who are seeing the recall, yes, you are welcome to see the recall, but don't take it to your heart, don't take it to your minds. It's a time to just relax, analyze, think, and introspect of what has happened in the last few months, how much you have put in, and what you are expecting now. All right. So today is the day to take a break. Today is the day to enjoy. Today is the day to relax. And don't take any decisions today because of the NEET result, because of the INI exam, because whatever answers you see here in recall, you may know that some are correct, some are not correct. So the only recommendation and request I have to all of you is please do not take any decisions about your goals now. Okay. Any decisions you take now will be reactions. All right. They will not be thought after decisions. So just relax, just take 2-3 days off and think about what has been and what should be next. All right. So do not begin without analysis, and that's exactly what we are going to do here. Analyze the exam. All right. So good evening, Nikesh. We will just wait for your friends also to join. And anybody who has any query, anybody who wants to ask anything, anybody who wants to add any options with the faculties, you're most welcome to do that in the live chat, in the YouTube live chat. You can add questions here. Most of the centers of INICET were comfortable, and but some of them were really distant, really far away from the main cities. I hope you have all reached comfortably to your centers, especially the students of the war-struck states, the peripheries, Rajasthan, Gujarat, Haryana, Punjab, and Jammu Kashmir. I hope you had a smooth experience. Good evening, Akanksha. Good evening, Suman. So I hope you have all taken the exam safely. Okay. Now, before we begin with the analysis, I want to just give you one analogy. In the last INICET, that is November 2024, the examiner must be a physician with fungal infection. Okay. Why am I saying this? I know it's a little funny to think because lot of questions in medical subjects, image-based questions in medicine, ECG-based questions, physiology में image-based questions, full questions of biochemistry, and lot of questions in patho-micro, lot of questions on fungi, septate hyphae, aseptate hyphae, lot of questions which made us analyze and think that, okay, the examiner must be a physician with fungal infection. This INICET, that is May 2025. I mean, I am sorry to all the examiners who have made the question paper, but this is the conclusion we are getting from the paper, that this INICET, the examiner must definitely be a surgeon with bronchial asthma. Paper was full of pharmacology questions and many questions on asthma and its related drugs. Lot of questions on surgery, oral surgery, general surgery. And so conclusion is basically, the conclusion in INICET, AIMS INICET is that, AIMS is the boss. Whoever thinks that you can predict the INICET pattern, or you can predict the the differentiation or the count of questions in every subject, no, you can't predict. It is unpredictable. It is an unpredictable exam. In the last exam, we thought that, oh, now medical subjects are giving a lot of importance. Physiology is being asked in a lot of extent. Biochemistry is being asked, patho-micro. And this time, like the old trend in INICET, like the old trend in AIMS and PGI separate exams, we have seen the paper was full of dental, subject questions. Lot of questions on dental subjects and very, very few questions on medical subjects actually. So honestly, हाथ जोड़ के प्रणाम है to the AIIMS authorities who keep it unpredictable, who keep it surprising every time, and leave us with a challenge every time that you can't predict how AIIMS is going to be. So just like every time, it was unpredictable. The questions seem to be easy. Questions seem to be moderate or simple because they were seen questions. Most of the questions आपको ऐसा लग रहा होगा कि यार देखा हुआ है, पढ़ा हुआ है, read questions और read topics. Most of the topics were कि यार ये ज्यादातर topics ना देखे हुए हैं, कहीं तो पढ़ा है, कहीं तो देखा है. Questions seem to be relatable. Questions seem to be not so difficult. What was difficult was the options. Very, very close options in a lot of questions. Okay, so usually this kind of scenario is very good for the studious kind of students, those who have really studied concepts, those who have read concepts. This is a very good exam for such students because that margin of option B versus C, it gives a very good edge to these students. Whereas every student will feel, all of you must be feeling कि यार paper ठीक था, doable था. Lot of the students have given me this feedback that ma'am, it was better than NEET. I mean, I felt the paper was much better than NEET. Yes, definitely. I was also much happier when I came out of the exam hall thinking that, oh, NEET was bakwas. This was much better. All right. But the options were really, really close. Okay. Lot of repeated topics. But definitely some new topics and many twisted questions. Okay, same question. Okay, same question of pan-facial trauma, reduced mouth opening word is added. And now you tell us whether it is submental intubation or cricothyroidotomy. So twisted questions, twisted options, tweaked questions. This was the scenario there. Okay, and yes, one very big subject, which is anesthesia, which is never taught to the dental students as a separate subject, but only is a little part of oral surgery, because as an oral surgeon, you need to know what tube to be put, what are the basic functions of an anesthesia machine. Full of anesthesia. The paper, surprisingly, and a lot of questions in anesthesia were overlapped with pharmacology questions, but at least 8 to 10 questions were, pure anesthesia. And when I say anesthesia, I mean general anesthesia and not LA. Okay, so this was one big surprise. This was one unexpected. AIIMS always asks anesthesia questions, which is why at DBMCI MDS, we teach anesthesia separately. The first recall today will also be by Dr. Ajay Yadav, who is none other than the author of the textbook of anesthesia. It's a very popular book in India. He teaches anesthesia here at DBMCI MDS, and he will be taking the recall of all the 8 to 10 questions which were there in the exam today. So this was not expected. Every time there are questions on anesthesia, but 1 or 2 odd questions. Not at all expecting 8 to 10 questions in anesthesia. All right. So what was surprise? Why AIIMS is the boss? First surprise is too many anesthesia questions. Very few medical subject questions. Okay. Yes, there was anatomy. Yes, there was pharmacology. But other than that, this is last exam, they asked ECG also. They asked image-based questions in physiology. They asked a lot of cycles in biochemistry. This time, one physio question, one biochem question, 2 odd medicine questions, 2 surgery questions, and that too, which is a resorbable suture and surgeons knot kaise lagate hain, and simple questions. All right. And again, old trend of asking too many dental questions, both clinical and non-clinical. Fourth, the continuing trend of asking a lot of oral pathology. I am very, very happy that this very, very important subject, which used to be, kind of very few questions used to be asked earlier, but in the last few years, we have seen lot of questions of oral pathology, especially the image-based questions asked in oral pathology. This trend has continued. This trend we are seeing since the last 2-3 INICETs, that lot of image-based questions in oral pathology, or even the description of the histopathological image is given, and that description-based questions, clinical image, histopath image questions that are, this trend continues. Much fewer IBQs. Last few INIs, we have seen lot of IBQs. I mean, at least 40 questions or 45 questions were IBQs in the last INICET. Compared to that, very, very few IBQs this time. Lot of image-based questions in oral path, few in radiology, the sagittal CT was asked, and few in pedo, few in endo. But no image-based question in oral surgery, no image-based question in prosthodontics, very, very few image-based questions. So this was the trend. Okay, the exam was skewed towards dental subjects, which I've already mentioned, that medical questions were very less, and the exam was skewed towards the dental subjects. And I think this is the reason why AIIMS is unpredictable. All right. But I'm sure most of you are happy. Most of you feel satisfied after giving this exam that at least what you have read has come in the exam. All right. Just quickly give me your feedbacks in the chat box right now. How was your overall assessment of paper? Okay. Before we go to the individual subject breakout, we have the number of questions, thankfully, here at DBMCI MDS at 6 p.m. sharp. We have all the 200 questions recalled. Thank you to a lot of students. Thank you to a lot of faculties who sat in the exam. Dr. Aishvarya sat in the exam. I sat in the exam. Dr. Divya, Dr. Shweta, a lot of in-house doctors sat in the exam. And we have the full paper ready with us. But according to you, what was the difficulty level? There is a poll going on there live in the chat, so please give your poll. But overall, you can text me also. What was the difficulty of the paper? Was it easy? Was it moderate? Was it difficult, or was it very difficult? Okay, so just give me that feedback, and then we go to the next subject-wise split of individual questions. According to me, the paper was moderate. But I want your feedback also. What did you feel? What was the level or difficulty of the paper? Yes, the options were confusing, Supriya. But overall, I mean, how did you like the paper? Moderate. Okay. So most of you feel it was moderate. All right. Okay. Okay. So now we come to the subject-wise discussion or subject-wise split of the questions. All right. And we begin with the first year subjects, which was anatomy. There were exactly 10 questions of anatomy, and I will call them straightforward, easy questions. Okay. Which artery supplies the teeth of the upper and lower jaw? Which cranial nerve supplies the teeth of the upper and lower jaw? Which of these is not a parasympathetic ganglion that is topographically associated to the trigeminal nerve? The internal maxillary artery, which is a terminal branch of the external carotid, arises at what level? Straightforward questions. The only difficult question, or the little odd question, was the question on symphysis menti. Slightly, the options, the question looked difficult, but the options were very easy. If you applied logic and common sense, I am sure you must have marked it correct. Dr. Monalisa is going to discuss these questions with you. But gomphosis, temporomandibular joint, okay, and very, very easy questions in anatomy, but definitely doable. Definitely doable. Physiology, there was only one question, which was on the, sudden, if you climb a high altitude suddenly, what will be the changes? Whether it will be respiratory alkalosis or acidosis or metabolic alkalosis, acidosis. So only one question. Biochemistry, pure biochemistry, if you see, there was only one question, which was the vitamin D wala question. Which of these is not a function of vitamin D in the body? Okay, and in physiobiochem, DADH, yes, there were around 2 to 3 questions. The mesial marginal ridge question and the primary tooth versus permanent tooth, the direction of enamel rods and everything. So 2 to 3 odd questions in DADH. So this was the distribution of the first year subjects. Now we come to the second year subjects. Patho micro combined, there were around 4 questions, but these were also the questions which could be put in other subjects. I mean, I could put these questions in oral path, like the question of the lip swelling. I could put this question on in perio, like the question of which of these is not an anti-inflammatory cytokine, the IL-1, IL-10, that question. So there was a lot of overlap. That if you have read perio properly or if you have read oral path properly, you could have answered these patho micro questions also. So not very, very difficult questions, but yes, moderate questions. In patho micro, 4 questions. Pharma. This was the bulk. Pharma was around 20 questions plus questions on anesthesia, around 4 to 5 questions of anesthesia, which we have put in general anesthesia. But lot of questions in pharma. Again, the questions of pharma were direct. Indication of aspirin, antiplatelet aggregating drugs are all except, direct. Which of these is an ARB, angiotensin receptor blocker, ACE inhibitor indication, and straightforward questions in pharma, one-liners, mechanism of action of local anesthetic, mechanism of action of, salbutamol, lot of questions on bronchial asthma here. So, which is why I told in the beginning that maybe the examiner had a lot of asthma and wheezing when he was making the paper. So, a lot of questions on metered dose inhaler and tremors caused by which anti-asthma drug and all those questions, but direct one-liner. So these are factual questions, and as we always say that pharma is very, very volatile. I mean, you would read pharma, you would understand pharma, but maybe you will not remember pharma. You will always be confused between, salbutamol and terbutaline. So there will always be confusion. So it's a factual subject. Everybody who has done revision of pharma properly, I am sure you must have had a very, very big advantage in today's exam, because if you have done pharma well, it was a direct question from pharma. I'm sure you will be a high scorer in today's exam. Okay, so pharma was very, very doable. Okay, pathomicro, pharma, and dental materials. Now, surprisingly, dental materials had 14 questions. Dr. Aishvarya sat across with me and told me that, Dr. Himani, 14 odd questions in dental materials, but they were moderate. They were moderate, and some were difficult, some were doable. Moderate to difficult is his analysis of the dental material questions. Usually, we don't expect dental materials to be asked a lot, but clinical dental materiology was asked. Lot of clinical materiology, that means the application of those materials in day-to-day use. Okay, whether it is the glass ionomer cement, lot of clinical materiology, not just the factual ones, but what you actually do in your clinical practice. So that was asked a lot. Okay, so this is the split of the second BDS questions. Coming to the third BDS paper, usually medicine and surgery have a dominating say in the INICET exam, but this time medicine questions were only 3 to 4, and they were also like the infective endocarditis question, but scaling and root planing was asked, so maybe you can put it in perio. Okay, questions on Still's disease, which we also study in OMR. So no direct questions in medicine. Very, very applied question. The only pure question in medicine was probably the patient who had come from the medicine OPD, who had tuberculosis, and he needs some dental treatment. So what will be the regimen? That was a combination question which was asked. और उसमें आपको ये multiple and options were really simple. Actually, if you looked at the option, one option was definitely wrong. Other options are correct. कि भाई आप उसमें जब तक active infective phase ठीक नहीं होता, you will not treat. Okay, if you give ATT for the patient for consecutive 2 weeks, and if the patient is constantly taking that drug, what do you call it? The patient is compliant on the drug, then you can do it. Or if there's an emergency procedure, you will do a negative pressure room, you will wear an N95 mask, and you will do, because emergency procedure you have to do. Okay, so that was also a question more of the clinical dentistry type. So if you're doing surgeries in patients of tuberculosis, if they are being referred to your oral surgery or surgery department or dental department, you know how to manage them. So they were very clinical applied questions in medicine. Next was surgery, that is a general surgery. Only 2 questions, and they were very, very easy. First question was, which of these is a resorbable suture? Resorbable sutures are all except, okay? So polypropylene, which is Prolene, except that all catgut and polyglycolic and all easy questions, okay? And the other question was about the surgeon's knot. Okay, single throw, double throw, same direction, opposite direction, straightforward questions, basic surgery. There was nothing that, that was new or that was difficult. Okay, so I would consider surgery was also fine. Okay, third is our own oral pathology. Now, this was moderate. I will not call it easy. It was definitely moderate to difficult. Lot of image-based questions, lot of applied questions. Those who have done oral path properly, those who have listened to Dr. Shrishti, I'm sure you must be able to mark these questions well. Again, oral path will be a deciding subject in the selection of this exam. With pharmacology, it is going to be oral path also. All right, so this was the distribution of the third BDS subjects. Coming to the final BDS subjects, OMR, 4 to 5 questions in OMR. Oral path was around 10 questions. Okay, not exactly 10. We are still distributing the subjects here and there, but broadly around 8 to 10 questions in oral path. OMR around 5 questions. Lot of questions on CBCT. Okay, that is image-based question is given, and you are asked that which slice is this, whether it's a sagittal slice, whether it's an axial slice. Okay, and simple questions if you know the basics of CT. And 2-dimensional imaging if you have to check for a rhinolith. Okay, now those who have read rhinolith as cyalolith, maybe you marked it wrong. If you have read it properly that it was a rhinolith, so you have to check the X-ray which is doing the scan of the nose. Plus the question had 2-dimensional imaging. Okay, so CBCT is definitely out. 2-dimensional imaging is asked, CBCT out. After you exclude CBCT from the options, choosing the answer becomes very easy. So the questions look difficult, but the options, if you read the question properly, if you just use a little bit of carefully reading the questions, you would be able to rule out the options and mark the correct answer. All right, so OMR was like 4 or 5 questions. Next was oral surgery. I will call oral surgery as definitely difficult. Okay. Although questions were there from exodontia, there was no question from LA except for the mechanism of action of LA, which we consider under pharma. No questions on cleft except palatography question, which we consider under prostho or ortho. LA question kuch nahi tha, cleft kuch nahi tha. 4 questions on orthognathic surgery. 3 questions on TMJ, including the syndrome wala question. 3 questions on trauma, 2 questions in trauma, 3 questions in exodontia. Simple questions, transalveolar extraction, pass ho gaya, ab kya karoge, metrogel add karoge, kaise karoge. Okay, and trigemino cardiac reflex or trigemino vagal reflex. 2 questions on this. Steroids, questions on preoperative steroids. So questions were there, but I will still call it difficult. Intubation, pan-facial trauma patient, and how will you intubate? Questions were there in pathology. Aspiration will give a yellow cystic fluid in all except margins or boundaries of the pterygomandibular space. So some factual questions, some clinical questions, some really difficult questions, some straightforward questions like pitch. So overall, I will call it moderate to difficult because choosing from the options was tricky. Okay, so that is there. Next, we come to prostho. Prostho also around 15 questions were there. 15 to 17 questions. Lot of questions on implants. Lot of questions on CD, RPD, FPD. Okay, some repeat questions were also there. Some new questions were also there. Again, prostho was of the moderate to difficult category. Next is cons endo. Dr. Aishwarya was able to recall 25 questions in cons endo. Of course, there is an overlap with pedo because traumatology is taught both in pedo and endo. But 25 questions, again, according to Sir, the paper was moderate to difficult. There were tricky questions, there were tricky options. But yes, again, some questions were straightforward. After cons endo, we go to ortho. Ortho around again 24 to 25 questions in ortho with overlap with oral surgery also. Like the questions on orthognathic surgery, questions in pitch, they are taught both in oral surgery and ortho. So if you remove the overlap around 22, 23, 25 questions in ortho, which is a lot. Actually, if you see that medical side paper was so less questions. After ortho, we come to pedo. Around 8 questions in pedo. Some image-based questions also. Stainless steel crown is asked. Space maintainers are asked. Okay. Habit is asked as a multiple right or wrong question. Okay. Habit is like thumb sucking karoge to kya hoga, tongue thrusting karenge to kya hoga. So not so difficult questions. So pedo was easy to moderate. Perio. Section D was perio, and perio. Questions as easy as fenestration and dehiscence. Questions as difficult as the anti-inflammatory cytokines seen in periodontal disease. And, मेरे को एक अचानक से क्वेश्चन याद आ गया, so I'm just scribbling it down here. So overall, perio was also moderate to difficult. And PhD, thankfully, AIMS was kind enough not to ask a lot of PhD questions, which is the trend usually in AIMS. PhD had around 8 questions. Okay, and some were new. So students felt it was moderate, not so easy, not so tough. All right, so I think this was the distribution of questions in the whole paper. What will be the deciding subjects? What will be the deciding subjects of the top 40 rankers? All right. Why do I say top 40? Because there are around 30 to 35 seats, depending on the category, depending on the EWS criteria, PWD criteria, all of things, and sponsored and this and that. Broadly, top 40 rankers of different categories come together. What subjects will decide whether they are in the top 40 or not? I will say pharma, oral path, oral surgery, conservative endodontics and DM, ortho, prostho. In my opinion, these will be the subjects which will decide the ranker. Okay. This is it from my side. Yes, it was a very doable paper. A lot of students were happy after the exam, but general anesthesia. So we have recalled 8 questions. Yes, nitrous oxide question you can put in pedo also, you can put in anesthesia also. But when the questions of MAC, the maximum alveolar concentration, and questions on diffusion, hypoxia are asked, you can put it in pedo, you can put it in GA. So with that overlap, around 8 questions in GA. So we have that ready. The first recall that we will have today is of anesthesia with Dr. Ajay Yadav. Overall, it was a moderate paper. It was a satisfactory paper. And I hope you've all done well. But whatever it is, the phase is over. This phase of one bulk of study is over. I will just finish the session here by telling that after this recall, do not take any immediate decisions. Do not look for solutions, life solutions immediately. Yes, you will look for answers, you will look for solutions of the questions, but ab main kya karu? That question should not be answered within hours or within 1 day or 2 days. Take a week, at least take a week. Think, इंट्रोस्पेक्ट सोचिए कि आपका क्यों पेपर अच्छा हुआ या क्यों पेपर अच्छा नहीं हुआ. इट इज वेरी इंपॉर्टेंट टू इंट्रोस्पेक्ट. दैट इंट्रोस्पेक्शन विल गिव यू द आंसर of what to do next. All right, so this is all from my end. Thank you so much, guys. If you have any doubts, you can still keep posting your questions in the recall. Any options that you feel are incomplete, you can help us complete with those options, and very soon we will be starting with the recall. All right, thank you so much.
Okay, fine. So guys, let's start. So honestly speaking, if you ask me from anesthesia point of view, this is too much actually, because the questions not only, I will say, difficult from dental point of view, in fact they are even difficult from NEET PG point of view also. So they are comparatively very difficult, no doubt about that. But as in a competitive exam, you know, you need not worry if something is difficult. It is difficult for everybody. So it's competitive exam. So if you don't know, that means other people also don't know. So don't get disheartened. Okay, fine. So without wasting time, let's start. Question number 1. Apneic oxygenation includes all these except pre-oxygenation, induction of anesthesia, maintenance of patent airway. What I got in choices: cessation of nasal cannula during definite airway, but I feel it should be continuation, not cessation. So just I'll make you understand. Apneic oxygen, the name itself is explaining everything. Apneic means you are oxygenating when patient is apneic. Clear? Means patient is not breathing. So you are giving oxygenation, and how you give oxygenation, you can place a nasal cannula. That is given by nasal cannula. You place a nasal cannula, and sometimes we place this nasal cannula deep into pharynx also. So what will happen, that there will be continuous flow of oxygen, and we use high flow. So through that flow, there will be some oxygenation in the body through passive diffusion. So patient is not being ventilated by himself, spontaneous or by ventilator, but we are still giving oxygen so that in blood some oxygen reaches by diffusion. Now, if you know about this, you can easily answer. Pre-oxygenation. Actually, if you ask me in this question, what they wanted to ask you about pre-oxygenation, what exactly pre-oxygenation is, because pre-oxygenation is actually very, very important part of general anesthesia. As the name suggests, pre-oxygenation means you are giving oxygen before induction of anesthesia. So you are giving oxygen before induction of anesthesia. And what we give 100% oxygen for 3 minutes. So patient is spontaneous breathing, means nothing has started. Patient is just lying on the table and you are giving 100% oxygen for 3 minutes. Means patient is spontaneously breathing. Patient is not in apnea. Clear? So 100% oxygen for 3 minutes, what it will do? It will replace all nitrogen present in lungs. You know, normally if we check our lungs, 70% it is filled with nitrogen. Air contains 70% nitrogen. So only 21% oxygen is there. So if you give, or 79% nitrogen rather, not only 70%, if you give 100% oxygen for 3 minutes, you will replace all nitrogen from there. Now whole of the lung is filled with oxygen, means we have increased the oxygen reserve of the body, so that patient will be able to sustain hypoxia for a longer period. Say you're not able to intubate the patient or you're not able to ventilate the patient. At least patient will be able to sustain hypoxia for a longer period and can prolong the brain damage. Fine. So in pre-oxygenation, patient is spontaneously breathing, so not apneic oxygenation. So this exactly is the answer. I'll go to other choices also. So actually that is what they wanted to know. What is the meaning of pre-oxygenation? Because if you know the meaning of pre-oxygenation, you can answer this question without seeing the other choices. Now let's go to other choices. Induction of anesthesia. When we induce, say we are giving propofol, most common uses, and propofol causes apnea. So before intubation, we will not remove mask. Patient become apneic and we are intubating. So that is going to take some time, albeit a few seconds. So that time oxygenation can be continued. So patient is going apnea, we are continuing oxygen. Or second method is that if you feel that patient is very vulnerable, cannot tolerate hypoxia. So what we do, we will we will put a nasal cannula from the beginning so that even during the intubation time also, just after induction, patient is apneic, still we are giving oxygen. So that is apneic oxygenation, correct? Maintenance of patent airway. See, patent airway. What is the most common cause of airway obstruction in an unconscious patient? Tongue falling back. So what we do, and this is very, very common practice. Tongue falling back, we put this Goodell's airway. So patient is still happening because we have just prevented the Goodell's airway and we are just preventing the tongue fall. So we are preventing the obstruction of airway, and by that time we will prepare tube, endotracheal tube, laryngoscope. So during that time, we will put nasal cannula through this so that patient remain oxygenated. So this is also a commonly done practice. If you feel, not commonly means routinely done, because we put this and preparing endotracheal tube and laryngoscope take few seconds. So patient can bear apnea for that second, but your laryngoscope is not ready and the cell is not working, tube is not ready, then we have to give apneic oxygenation. Now, continuation of nasal cannula, that's what actually already we have discussed. Definite airway. What is the meaning of definite airway? Definite airway means we are intubating the patient. Mask ventilation is not definite. Definite means tube should be in the trachea. So tracheostomy or intubation are only considered as definite airway. So till we achieve the definite airway, we are putting nasal cannula and we continue apneic oxygenation. So it is continuation. What I got is cessation, because if you are stopping nasal cannula, you are stopping the apneic oxygenation. So you are stopping the apneic oxygenation. So then there become two choices, A and D. So I think from one of the student I got also, it is continuation, not cessation. Then it is A. If you say cessation, then both choices become correct, A and D. So it is continuation. Now I think you got it. I'm going little detail because these things are very new for you. So apneic oxygenation means patient is in apnea, not breathing, not ventilated, and you are putting nasal cannula and giving oxygen to the patient, and patient is getting oxygen by passive diffusion. Pre-oxygenation, patient is spontaneously breathing. So that is not apneic oxygenation. After induction, patient become apneic by giving propofol. Propofol causes apnea. During that time, patient is apneic, but you are oxygenating. Maintenance of patent airway, I told you, we put an airway, but patient is apneic. You have prevented tongue fall, and till you ready your equipment, you are using nasal cannula. So that is also apneic ventilation. Or till you intubate, you are putting nasal cannula and you are continuing oxygenation. Clear? So all these things are apneic ventilation, only A, correct? Question number 2, after sedation with nitrous oxide, which of these is done for prevention of diffusion hypoxia? Actually, rather than sedation, it should be anesthesia, but still we can accept sedation, fine. 100% oxygen during induction for 5 minutes. 100% oxygen during recovery for 5 minutes, 100% oxygen during induction for 10 minutes, and 100% oxygen during recovery for 10 minutes. Two very important property of nitrous oxide you should know. During my class also, those who have attended classes, I had already told you that you have to know each and every detail about nitrous oxide. So every exam, if general anesthesia questions will be there, maximum questions obviously are expected on nitrous oxide from you, because nitrous oxide in combination of oxygen, that is 50% oxygen and 50% nitrous oxide, you are using as Entonox. And many dentists, they are using Entonox for the dental procedures. Them by themselves only, not even without calling us. So nitrous oxide, you have to know everything. So and this time also, I think 2-3 questions are there from nitrous oxide. So nitrous oxide, two very important property I like to tell you. One is that second gas effect. See, there are many properties. What I'm telling you from the questions point of view, which questions has been asked in this exam. Otherwise, a lot of properties of nitrous oxide that you should know. Second gas effect and diffusion hypoxia. These two important property you must know. Now, what is that? Second gas effect, lot of physics is required to understand that. We need a 3-compartment model to understand that, but that details are not required for you. So I'll tell you a very simple method to understand the second gas effect. Second gas effect is simply nitrous oxide increasing the concentration of volatile agents. So when we give general anesthesia, now you have to just understand basics of general anesthesia. Although if you have attended my class, then you know that basics, but maybe some of the students are there who have not attended the classes. So general anesthesia, I'll just give you a brief in 2 minutes. First, we pre-oxygenate. And already I have discussed why we pre-oxygenate. And then we do induction. And induction is done with IV agent. Most commonly used is propofol, and that will make patient unconscious. When patient become unconscious, then we have to intubate the patient. For intubation, you have to use muscle relaxant. Then we use muscle relaxant because we need this pharynx, larynx muscles to be relaxed. And once patient is relaxed, we intubate. Now, after intubation, now anesthesia is maintained on. Maintenance of oxygen is on oxygen, which is minimum 25% plus 75% nitrous oxide plus one of the volatile agent. The volatile agents include halothane, isoflurane, sevoflurane, desflurane. And then we are using non-depolarizing type of muscle relaxant for maintaining relaxation for surgery. So this basic you need to understand the questions which we are going to discuss. So what will happen? As I told you, we are giving oxygen, nitrous oxide, and volatile agent. The second gas effect is that this nitrous oxide increases the alveolar concentration of volatile agents. So if you are giving nitrous oxide will carry more molecules of volatile agent from anesthesia machine into the alveoli. This is second gas effect. Word itself explains everything. Second gas, one gas, that is nitrous oxide, increasing the concentration of other agent, that is second gas effect, that is volatile agent. Clear? Now at the end of surgery, obviously you are going to stop nitrous oxide. So now say I immediately stop the nitrous oxide. So what will happen? Now during maintenance, we are giving nitrous oxide from machine, reaching the lungs, and from lungs it is getting diffused into blood, and through blood it is reaching the brain. Now when you stop nitrous oxide from machine, now lungs will become empty. You're not giving nitrous oxide. So lungs will become empty, and now the concentration in blood and tissues is more as compared to nitrous oxide. And you know that gases flows by gradient. So there is higher concentration in blood compared to nitrous oxide. So nitrous oxide from blood will gush into lungs. So if immediately nitrous oxide from blood will gush into lungs, whatever the oxygen present in lungs will be diffused out. So this is called as diffusion hypoxia. So word again itself explain that oxygen is getting diffused out of nitrous oxide and that is causing hypoxia. Clear? Now how to prevent it? Now you can automatically understand that at the time of recovery, when you stop nitrous oxide, you try to fill lungs with oxygen. And how you can do that? You start giving 100% oxygen at least for 10 minutes. Because this process of diffusion hypoxia take 5 to 10 minutes. So to be on the safer side, we have to give 100% oxygen for 10 minutes. Now clear? So diffusion hypoxia means nitrous oxide from blood gushing into lungs at the time of recovery when you have stopped nitrous oxide from machine, replacing all oxygen from there, creating a hypoxic state called as diffusion hypoxia. To prevent this, simply we have to give 100% oxygen for 3 minutes. Got it? So that is what they have asked. You have to give 100% oxygen during recovery for 10 minutes. So answer is D. Question number 3. Which of the following among these is intravenous induction agent? This is very easy. And I don't think anybody among you would have got it wrong. This, I will say, is the easiest question of all 11 general anesthesia questions which I have got. Thiopentone, IV induction agent. Propofol, IV induction agent, most commonly used, almost always used. Nitrous oxide is an inhalational agent, not given IV, given through inhalational route. So it is an inhalational agent. And ketamine is also given IV, so IV agent. So 1, 2, 4. 1 to 4 is choice A. Question number 4. Again, very difficult question, in fact. It is, if you really ask me, it is actually PG level question. But anyway, they have asked, so we have to discuss. And I'll tell you, there are many formulas to discuss it, but I'll tell you very simple way. If you would have used probably your common sense, you would have done it. On the anesthesia delivery system, the factors responsible for increasing partial pressure of inhaled agents are all except solubility of the agent in respiratory exchange system, volume of gas in external respiratory system, flow of gas from anesthesia machine, second gas effect. Now, just increasing partial pressure. See, for other things, we are using concentration, but partial pressure is better term for concentration. Means the question is, what are the ways, say this is alveoli, this is lungs. What are the ways by which you can increase the concentration or partial pressure, or you can say concentration? Simple. This is lung, alveoli. So what are the methods by which you can increase the concentration or partial pressure of this volatile agent or inhalational agent in lungs? Very simple. Now you can start thinking with your common sense. Say, just I'll make a small schematic diagram. This is the anesthesia machine. And from anesthesia machine, we are giving inhalational agent. And this, I will say, is the breathing circuit. Breathing circuit. And this breathing circuit is connected to, say, endotracheal tube. This is endotracheal tube. And this, I say, is lung. I'm just making lung. This is lung. So that is how a drug or a volatile agent, which I'm saying here as showing as a green line, dotted lines, they are reaching the lung from machine. And inhalation agent means they are talking about mainly volatile agents, halothane, isoflurane, desflurane. And I told you what we give combination: oxygen, nitrous oxide, and volatile agent. So you can say these volatile agents, they are using these gases to reach the, because they are using very small concentration, just few vapors. So these vapors from anesthesia machine reaches the lungs, with these gases, with this gas flow. So gas flow, through this gas flow, which consists of oxygen and nitrous oxide, these volatile agents get attached and reaches the lungs. Okay, now you can understand each and everything. Now, how can I increase the concentration of this volatile agent in the lung? That is what they have asked. Okay. One thing is I can increase the respiratory rate. If I increase the respiratory, say I am using 10 respiratory rate. So if I'm using 10 respiratory or I'm using 20 respiratory rate, so means more gas is going faster. So I can increase the respiratory rate. One. Secondly, I can increase the flow so that say I'm giving 3 liter or I'm giving 6 liter. So 6 liter carry will more gas. So this is another way that I can increase the flow. Fine. This is one part from this part. Now see the second part. Achieving this concentration also depends on how much it is exiting into blood. Say this is blood vessel. So if this agent is reaching the blood to reach brain, now how fast it is exiting the lung will also depend that how fast we can induce. Got your point? If this is a bucket or say this is a cup, filling of this cup will depend how fast we are filling this cup, and second, how fast this cup is getting emptied. If it is not getting emptied, emptying rate is very slow. It gets filled up already. So there is no benefit of adding more. So how fast it is taken up. So how fast it is taken up depends on the cardiac output. If cardiac output is more, means if there is more blood flowing through it, it will take faster. So concentration will fall and more concentration will come from anesthesia machine, because you know that flow depends on the gradient. Fine. So cardiac output is more gas will be taken up. So flow can be increased or concentration can be increased, or solubility, blood gas solubility. If a agent is rapidly soluble, it will be carried very fast. If something is easily soluble, blood will carry it fast. If it is not easily soluble, how blood will carry it? So this gradient will not be wide. Fine. So it depends on the solubility also, how fast a gas is getting soluble. So now with understanding all these points, I told you this is exactly a PG level question, but since they have asked from you, so we have to discuss and I have to make you understand. Although they have many formulas, we are using formulas, but of course that much details are not required for you. So with understanding this background, let's go back to the question and understand it. Solubility of the agent in the respiratory exchange system. Yes, if you increase the solubility, I told you, more agent will be taken up fast because the gradient will be wide. So this is correct. Now, volume of the gas in external system. There are two things. I'll come back to this choice. I'll go to third choice first. You will understand. Flow of gas. I told you the very good method. You just increase the flow so that more agent can be delivered. So flow. Second gas effect already is the property of nitrous oxide that can increase the concentration or partial pressure of agent in the gas. So this is also a factor. So now the remaining choice becomes B. So you can do by exclusion. Now, what do you mean by volume? Don't get confused with flow and volume. Volume means if I am using more gases, volume, I have increased the volume. If you increase the volume, flow remains same, there will be more dilution. Understand? Say there is 5 liter of gases which are coming and they contains, for example, say 100 molecules of volatile agent. Now molecules of volatile agents are still 100 and I make this volume to 10 liter. So it will get diluted. So partial pressure will be reduced. Understand? So answer will be B. So don't really get disheartened. I don't think anybody would have got this question right. And if you really got it right, then I suggest you leave dental and join anesthesia. But anyway, let's go to the next question. In a patient with pen facial fractures and reduced mouth opening, which of these is the choice of intubation? Orotracheal, nasotracheal, submental, cricothyroidotomy. Again, there are some things in the questions which can really help you in solving this question. They have asked choice of intubation. So that automatically rules cricothyroidotomy. Intubation. It is not the intubation method. Cricothyroidotomy, what we are doing? We are placing a needle in cricothyroid membrane, and through that needle, we will be ventilating the patient. Although there is a method of retrograde intubation by doing cricothyroidotomy, that is obviously not possible if adequate mouth opening is not there. So that means we will not go. Now the catch in this is reduced mouth opening, not absent mouth opening. Reduced. How much reduced? We don't know. You know, we are doing Mallampatti classification, which is important from your point of view also. Don't get scared by looking at this term Mallampatti classification. You have to not what you are seeing each grade. Patients are graded from 1 to 4 based on the mouth opening. So what do? We ask the patient to open the mouth, and by looking at the structure seen, patient is categorized in 1, 2, 3, and 4. 1 means all structures are seen, which we are planning to see, like tonsillar pillar, soft palate, uvula, fauces, everything is seen. Means mouth opening is adequate. Into mouth opening is little restricted, but still you can easily intubate. In grade 3, mouth opening is restricted, but with the difficulty you can still intubate. Grade 4, no mouth opening, so oral intubation is not possible. So they actually did not mention absent mouth opening, reduced. It can be Mallampatti grade 2 or Mallampatti grade 3, where oral intubation is very much possible. So since it is a pan-facial fracture, maybe Leaford type 3, then in that case, nasal, we will avoid. You all know we expect nasal fracture. And if there is basal skull fracture, that is an absolute contraindication for nasal intubation. So that is ruled out. Cricothyroidotomy is not the method of intubation. It is a method of ventilation. So this is also ruled out. Now, orotracheal and submental. Pan-facial fractures, you know, almost always, or rather always, they are doing this mandibular fixation. Although we always ask oral surgeons before surgery that they are planning for fixation, but pan-facial fractures most often or almost always, I can say that they do the fixation. So if fixation is there, we will not be able to extubate the patients if we have done the orotracheal. So since mouth opening is there, so we can put orotracheal intubation. And you very well know that in mandibular fractures, mouth opening is most often reduced due to pain. Most often the cause is pain. As soon as we give anesthetic agent and muscle relaxant, patient is relaxed and we can intubate. This is very common when you will go to practice and your internships also, you will be seeing it very commonly that trismus is because of pain. Once you give induction anesthesia, it is okay. So we will do oral intubation like a normal case. And then since they are doing fixation, IMF, so obviously these oral surgeons, they will pull this tube through the submental route. So of course, the best choice would be submental. Got it? Question number 6. Minimum alveolar concentration of nitrous oxide is 105%. This means what? Higher lipid solubility, low potency, low margin of safety, fast recovery. If you know MAC, you can understand this question without knowing anything. And I think MAC you have to know. What is MAC? Minimum alveolar concentration, as the name suggests. This is the minimum concentration of an agent required to produce the desired effect. So it is synonymous of concentration minimum that we use for IV agents. IV agents, we say minimum concentration which produces effect. For inhalational agents, we are using through respiratory route. So we will be using, instead of IV, we will be using alveolar concentration. So it is the minimum concentration required to produce effect in 50% of the subjects. Now, if an agent has low MAC, it will be more potent. Or other words, you can say MAC is inversely proportional to potency. Very simple. Say I have two agents, A and B, and both are producing X effect. Say, for example, A is producing X effect at 1%, and B is producing X effect at 2%. So, which is more potent, A or B? Of course, A, because it is producing the X effect at 1% concentration, while B will require double concentration to produce the same effect. So, lesser is the concentration, lesser is the MAC, more will be the potency. Clear? Now, potency 105%. What does that mean? That means even at 100% concentration, nitrous oxide is not able to produce the anesthesia. And you cannot give more than 75%. That's why I told you, you have to understand this basic, that minimum we will use 25% oxygen, otherwise patient will develop hypoxia. We need minimum 21% oxygen to survive. So here we are using 4% extra to just to compensate for some leakages. So we can only give 75% nitrous oxide. So this will produce a it's hanged. Normally it doesn't get hanged. Okay, I'll keep it. Okay, fine. So fine, that's what I was telling you. So now let's go to the question and you can very well understand this. So 105% means very low potency. Very, very low potency means this agent is not able to produce full effect even at 100%. And maximum we can use is 75%. And that is the reason why we are using volatile agents. I told you we use oxygen 25%, nitrous oxide 75%, and then volatile agent, because oxygen is not an anesthetic agent. It is needed for survival. We are using nitrous oxide, which is only providing 75% of the anesthesia. For remaining, we have to use the volatile agent. Fine. Now we can understand why we are using volatile agent along with nitrous oxide. So MAC indicates potency. So if you know that MAC indicates potency, if you know this thing also, then there is no other choice. It is solubility, it is safety, it is recovery. So automatically the question becomes, means they are talking about potency. Even if you don't know whether it is indicating low potency or high potency, still you can answer it. Which of these opioids can be used during surgery if given intrathecally? Meperidine, morphine, methadone, fentanyl. I will say totally injustice for dental students, because none of the dental student is going to give spinal anesthesia. So asking questions related to neuraxial blocks, spinal we call as intrathecally, means into the meninges, means into subarachnoid space, into meninges. So this means we are talking about spinal. So I really don't know why this question has been asked, because it is not even related to general anesthesia. General anesthesia, the drug which is used in dental practice, principles of anesthesia may be understandable, but asking spinal from dental in dental exam is, I mean, I don't know why. Anyway, they have asked, so again we have to discuss. So what we meperidine, pethidine, see, very important thing, just I like to tell you again, of course, no need to waste time on that. So what I would like to tell you is that the drug which we use through meninges must be preservative free. Otherwise, this preservative can cause arachidonitis, which can cause adhesive arachidonitis and can cause permanent paraplegia. So drug, two properties, must be preservative free. Secondly, it should be short acting and should produce least respiratory depression. So meperidine is pethidine, not used because it contains preservative. Morphine can be given. Preservative preparation is available, but morphine is very long acting and very prone for respiratory depression. So we cannot use intrathecally. And methadone is used for chronic pain management or opioid withdrawal. So it is also not given intrathecally. So the drug that is given is fentanyl. Because so I think just what you maybe they thought they want you to know that fentanyl is short acting, so causes less respiratory depression, so can be used. Maybe the examiner wanted to ask this concept from you. Question 8. Which antiemetic used in perioperative period, if not used cautiously and high dose, would cause avascular necrosis head of femur? Metoclopramide, 5-HT3, not H3, it should be maybe, I think, 5-HT3. That is ondansetron, granisetron. So I don't think it should be H3, it should be 5-HT3. Ondansetron, granisetron, palmisetron, they are commonly used. Metoclopramide is commonly used. S2 antagonist, ranitidine is used but not preferred nowadays. And dexamethasone is also an antiemetic steroid. So this you know, this you should know, because dexamethasone is commonly used as an antiemetic agent. We are using routinely it as antiemetic agent, but given IV as a single dose and even in high dose, of course, will not cause avascular necrosis of head. But just they wanted to know from you that steroids can cause avascular necrosis of head. That they wanted to ask. So they just use antiemetic. So to know that dexamethasone has a very well proven antiemetic effect, because this is just to confuse or make question very hard, because you know that I know all of you will be knowing that metoclopramide, 5-S3 antagonist and S2 antagonist ranitidine are antiemetics. So you will be thinking of choices among these, and they wanted to know that dexamethasone is antiemetic and prolonged use of steroids. I think all of you know, all of us know that it can cause avascular necrosis, but that is actually very prolonged and very high doses. So just using as antiemetic in perioperative period, I won't say that it will cause. Yes, post-operative it is used for very prolonged period, particularly cancer patients we are using for months and months. There has been case reports of avascular necrosis. Which of these do not cause competitive neuromuscular blockade? This comparatively, I will say, is definitely an easy question. Rocuronium, mivacurium, succinylcholine due to Bucrare. So it is an easy question because I know that basics of muscle accent, you know that muscle accents are depolarizers and non-depolarizers. Depolarizers only include succinylcholine or succinylcholine. Rest all drugs that you know we are using, rocuronium, deuterbocrare is obsolete, mivacurium, atracurium, cisatracurium, vicuronium, they all are non-depolarizers. So only depolarizer that is being used is succinylcholine. So mechanism of action of succinylcholine, what is the meaning of depolarization? Means it is acting by depolarization. Means it will act like acetylcholine. It will bind to the same receptor site at which acetylcholine binds, leading to channel opening, depolarization, action potential, and muscle contraction. So when you give succinylcholine, you see millions of molecules of succinylcholine reaching all neuromuscular junctions, causing muscle contraction in all body muscles that we can see clear cut as fasciculations in all body muscles. Then why relaxation? That's a rule of physiology, you know, from very basic knowledge of your physiology. Persistent depolarization will make the membrane to become refractory for a transient period. That period is a period of relaxation. So during that period, even if acetylcholine is present there, it will not be able to act because the membrane is refractory. So it is producing relaxation by causing depolarization. Non-depolarizers are competitive. Means they block the same site of receptor at which acetylcholine is supposed to bind, preventing acetylcholine to bind to that receptor. Clear? So that is competitive antagonism. So you must know what are depolarizers and non-depolarizers. And all you know that depolarizer is succinylcholine. So if you know this fact also, you can answer this question. Odd man out if you also rule out it is succinylcholine. So rocuronium, mivacurium, D-tuberculare, all are non-depolarizers. So they are competitive antagonists. Fine. If you don't know also, you can just know that this is an odd man out and there are three choices. So what these three should be. So succinylcholine, you have to rule out. So it is 1, 2, 4. 1, 2, 4 is C. Clear? But you have to know about general anesthesia. You must have read general anesthesia and at least in basic details. Now, question number 10, which of these agents does not belong to the category of controlled drug substance? Propofol, ketamine, fentanyl, midazolam. That also you can answer. Controlled drug, schedule X, are the drugs which are having abuse potential. So I think all you know, opioids and benzodiazepines, they have abuse potential. Fine. Abuse potential. Now, so I think everybody knows this. So maybe you got stuck at propofol or ketamine. Now, ketamine, you know, is hallucinogenic. The major side effect of ketamine is hallucinogenic. And that is why you know that ketamine is a very, you can say, abusive drug. Even ketamine available in tablets also. Because ketamine is hallucinogenic and ketamine is prepared from bhang. And bhang is addictive. So obviously it has to be controlled. Now, honestly speaking, among these choices, it is propofol. But propofol also has got addiction potential. Compared to these drugs, no. Compared to these drugs, I will say very low, but it also has got addiction potential. And the classical example of this is Michael Jackson. You know, the cause of death of Michael Jackson was apnea due to propofol. He was propofol addict, but propofol is the addiction of last resort. You know, Michael Jackson, he has abused everything which is available in the world, and last resort was propofol. So he used propofol, and I told you propofol has got apnea, it caused apnea, and that was the reason he died. So propofol is also abuse potential, but since it is not available, cannot be used by common people, and it has got a risk of apnea and death. So that is why it should be in the schedule X, abuse potential. But these, when you have to choose among these, we will be choosing propofol. So this is should be an actually easy question, but they make it little difficult also. Then atypical pseudocholinesterase will cause prolonged apnea if used with rocuronium, atracurium, succinylcholine, atracurium. This also you can easily answer if you don't know the details and you just know that which among these drugs is metabolized by pseudocholinesterase. Means if you know succinylcholine is metabolized by pseudocholinesterase, you can easily answer this. Atypical pseudocholinesterase, also called as abnormal pseudocholinesterase, means patient is having abnormal pseudocholinesterase which is not able to metabolize succinylcholine. So obviously patient will have prolonged apnea. So atypical pseudocholinesterase will prolong apnea if used with, of course, succinylcholine. Clear? So that is the questions which I got. Questions definitely, again, I will say, were really very, very difficult, not only difficult. Now, just let me see the queries. Now I'm only joining the YouTube session. Otherwise, I mean queries. Questions which I got. Question. So now let me just in 5-10 minutes go through queries because I think we are running over the time. So from the beginning, hello with Joe. This is Dr. Himani. So Dr. Himani, I am not in bachcho. Okay. Okay, madam, please make sure to give stereo number. Okay. Was tough equal to NEET MDS. Was toughness equal to NEET MDS? I don't know, you are asking about the whole exam, but if you, I told you already, if you are asking about anesthesia question, toughness was more than NEET PG. Okay. Uh, okay. Akansha says cessation of oxygenation while maintaining a patent airway. See, I told you, if you are sure that it is cessation, then it cannot be pre-oxygenation, or if it was a multiple choice. If you put cessation, then the choices will be A and D. There is no second thought about that. So I don't know whether it was a multiple choice. If it was a multiple choice question, then choices will be A and D. If it is a single choice and you are sure it is cessation, then it would have not been pre-oxygenation. So Akansha, if you can clarify me on that, it will be good. Then it will not be pre-oxygenation if cessation was there. Okay, all are sure about cessation was the option. Then I don't think pre-oxygenation was be there, or there must be something else. Uh, then it is A and D for sure. Okay. Okay. Brainy asks, sir, what is the difference between second gas effect and concentration effect? Very good question, Brainy. That's why I think you kept your name Brainy. Okay. I told you there are actually a lot of properties. So I discuss only the properties which are related to the questions asked here. So what he has asked is what is difference between concentration effect and second gas effect. See, the difference is that one leads to other. See what I tell you. Now, since you have asked this, so I have to go in little detail to make you understand. And the next query is diffusion hypoxia by Divya. Okay. See, when we are giving nitrous oxide, whole of the lung is filled with nitrous oxide. 75% of the lung is filled with nitrous oxide. Now say there occurs sudden uptake of nitrous oxide into blood. So the concentration of nitrous oxide will not be reduced to half. It will be reduced much more, because you know that gases do not work on the principle of mathematical numbers. They work on the principle of concentration gradient. There was no nitrous oxide in blood or less in blood. So nitrous oxide will immediately gush in the blood. So concentration in lungs will be reduced. Now concentration gradient between lungs and anesthesia machine is widened. So more nitrous oxide from anesthesia machine will gush into lungs. So that will increase the concentration of nitrous oxide in lungs much more than what we are expecting. So this is called as concentration effect. That means nitrous oxide increasing its own concentration in lungs is called as concentration effect. Now nitrous oxide coming from machine also is carrying volatile agent. So more volatile agent is drawn into lungs. So the achieved concentration of volatile agent will be more. So that is second gas effect. And I told you at the end of surgery, when you stop nitrous oxide from machine, lungs will become empty. So more concentration on blood side. So nitrous oxide from blood will gush into lungs, replacing all oxygen from there, creating a hypoxic state called as diffusion hypoxia. I hope it's clear now. अबे से सर थोड़ा जल्दी जल्दी बताएं. Okay, अबे. Why you want to jaldi or able to pick up fast, or you have to go somewhere? Cemental over correct, low potency correct. Yes, competitive blockade, propofol sir. Yes, competitive ask. Yeah, it is correct, competitive. Yes, due to Bakrar is competitive. All non-depolarizers are competitive. Only succinylcholine act by depolarization. Rest all non-depolarizers are competitive. There is some phone, I think the next faculty may be waiting. Anyway, later if you have queries, you can, I know I go a little over the board. No, Raftar, it will be 10 minutes. I already told you. Where is the question? We have to give oxygen for 10 minutes, not 5 minutes. There is no need to think, Raftar. It is 10 minutes. I think there are no more queries. So I'll just pack up. Fine. Later you can ask question. Maybe I think the next faculty is waiting. I'm getting.
So, hello, am I audible? Yeah. Hello, am I audible? Hello, students. Hello. Hello, everyone. Okay, yes, I'm audible. So let's start with the session. So I think firstly, I would like to ask everyone, how was the anatomy question? Okay, yes, Rupendra Kaur. Yeah. So how was anatomy? How you feel? How was the level of anatomy? I feel anatomy was easy for you. I think anatomy is easy, but I don't know what other students feel. It was okay, I think, because I am seeing the most of the questions are being repeated, or the topic is definitely repeated. But I think they are giving more importance to the cranial nerves and not. So let's see. Let's start with the discussion. So yes, Akansha Verma. So everyone is audible and everything is okay. So we can go with the quick explanation of the MCQs being asked, the recall MCQ. So let's start with that. So let's start with the first MCQ. Okay. So whoever wants to mark their answer, they can mark. One of the joint which is between the tooth and the socket is known out. So I think I have started my lecture with the general anatomy, and the general anatomy chapter. We have discussed about all types of joints. We have discussed about fibrous joint. We have discussed about the synovial joint and the cartilaginous joint. So what my dear students has marked, this is a very easy one, I think. And everybody is knowing the right answer will be gomphosis. Why the gomphosis is the right answer? Actually, it is a type of specialized fibrous joint. So it is a fibrous joint, and it is the connection of tooth in the socket, and there is this is also called as peg and socket joint. So I would like to show you an image for it. So you can see this joint is the gomphosis, which is called as peg and socket joint, and there is a surrounding ligament which is called as periodontal ligament. So the connection is established by the dense connective tissues, and they are expanding the gap between the tooths and the sockets. Gomphosis is actually classified as a subtype of fibrous joint, and it is also considered, if I go with the functional classification of gomphosis, as a structural classification will be the fibrous joint, and if I go with the functional classification, gomphosis is a type of synarthrosis. So I think most of you must have. So what is the functional classification? The functional classification is synarthrosis. And what do you mean by synarthrosis? That joints, they are not mobile. And also it is a fibrous joint. Which type of fibrous joint? So it's a fibrous joint which is having the periodontal ligament connecting it. So is it okay, everyone? Peg and socket joint is gomphosis. Yeah, Rupendra, yes, it was easy and a straightforward question. So most of the students are telling, yes, ma'am, it was easy and straightforward question. So no doubt about the incorrect options. Everyone has marked it right. So let's go with the second one. Good one. This was the correct one. So I'm so happy. So let's move on to the next. I think this is also easy one, Walid. This is the TM joint, the temporomandibular joint, a very important joint for all my dear dental students. And why it is a very important joint? Actually, it can't be it can't be a simple hinge. The reason why it can't be simple hinge, because there is a it's a complex joint, and the reason, so most correct will be it is a condylar and a complex joint. So I will go with the condylar joint. So why it is a condylar joint? So the reason is TM joint is classified as a complex condylar joint. So why I will tell you why it is called as complex condylar joint, because there is a fibrocartilage which is dividing the joint into two compartments. So let's see here. So if you will see this image, in which I would like to slightly highlight this image, and you can see that the joint cavity of the TM joint, that is bicondylar joint, and it is a complex joint, because inside we can see there is an articular disc, and this articular disc is dividing the whole of the joint cavity into two compartments. One compartment like upper, and the one is the lower. So there is a upper and the lower compartment, and the upper compartment having the gliding movement. Along with it, there is also a rotational movement. So this is the reason we will go with the most correct answer as a complex joint, that is condylar complex joint. And it involves a multiple articulating surfaces, and the whole cavity, the one joint cavity, that is the TM joint cavity, is subdivided into two compartments, the one above and the one other below. So it's a shape of articulation is like a condyle. So TM joint is a synovial condylar hinge variety, but it is a complex joint because it is involving inside a fibrocartilage. So it is having a fibrocartilage made articular disc, and so it is having a superior and inferior compartment. So is it okay, everyone? So if you want to know more, the superior articular surface is formed by the mandibular fossa. As you can see, there is a mandibular fossa which is forming the superior articular surfaces, and the articular surfaces is concavo-convex as shown in the image. The inferior, there is articular surface formed by the head of condyle. As you can see, the head of condyle, mandibular head of the condyle, is convex. So everyone, is it okay? So let me check with the messages. So it's oh, Florence, no, so sorry. So Florence has marked simple one. No, dear, it's not the simple one. Why? Because it is having an articular disc, which is making it is a complex joint, compound complex joint. So everyone, Akash, Varma, and Rupendra, and the fluorescence, can we move on to the next MCQ? So I think this is okay. Okay. Compound is also not the right, because compound means more than two bones are articulating, and it is obviously not the simple one. Okay, Parneet Kaur. So I'm okay. Few of the students has marked it wrong. So no worries, but most of you have marked it right, I think. Got it right. Okay, Banerjee, a thumbs up for you. Banerjee has got it right. Very good. So no worries. Let's solve it. Okay, many of the students has marked it hinge. Okay, the crux point which you have to pay attention was, it was the articular disc which is dividing it into two joint cavities, two compartments. Same goes with the knee joint, where we have got a knee meniscus which divide the knee into two compartments. So that is also a, but knee, there is more articulation than two bones. So it is a compound complex joint. So I think everyone has got this explanation. Let's move on to the next MCQ. That is question number 3. Maxillary artery is the terminal branch of ECA, external carotid artery, arising at this level. So many times we have talked about the maxillary artery. And if you remember, I have given you the description of all the branches of external carotid artery and maxillary artery, and the key muscle of infratemporal fossa, which is dividing the maxillary artery into three parts, that is lateral pterygoid muscle. So here there is alveolar process, pterygoid, neck of mandible, and pinna. So if I have to go with the most correct answer, I will definitely go with the right answer. That is the maxillary artery, which is the larger terminal branch of external carotid artery. It is arising behind the neck of mandible. So I will go with behind the neck of mandible. And it is, when it originates, it lies inside the substance of parotid gland. It lies inside the substance of parotid gland. So actually there is a lateral pterygoid muscle. This lateral pterygoid muscle is considered to be the key muscle of infratemporal region. And why it is considered to be a key muscle of infratemporal region? Because it will divide the maxillary artery into three parts: the first, the second, and the third part. So if you will see, as it arises behind the neck of mandible, it gets embedded inside the parotid gland substance and between the ramus of mandible until the level of sphenomandibular ligament. So from the behind the neck of the mandible till the level of sphenomandibular ligament, it is considered as the first part. What about the second part? The second part has got a variable relation. Either it can be superficial or it can be deep to the lower head of lateral pterygoid muscle. What about the third part? The third part of the maxillary artery, which is also called as pterygopalatine part, which is traversing through pterygomaxillary fissure, or sometime it pass between the two heads of lateral pterygoid muscle. So is it okay? I think this must be marked as the right answer. Neck of mandible, no fluorescence. Neck of mandible, yes. Mondal has given the right answer. Sobik Mondal has given the right answer. So you can see here also, this is exactly the maxillary artery which I'm talking here. So you can see this is exactly the maxillary artery. And this is exactly related with the neck of mandibular region. And neck of mandible is the origin point where it is traversing from the external carotid artery. So maxillary artery terminal branch of ECA, yes, it's the last terminal branch of ECA, which is given exactly at the neck of mandible. As you can see in this relation also, this is the mandible and this has been cutted here to show you that it is related as the first part arising from the neck of mandible. It aroses and then it divides bilateral pterygoid into three parts. I know everybody is knowing its branches and not taking your much of time because you want the quick recapitulation and seeing all the MCQs being asked. So first part is having 5 branches. I have given you the mnemonic, the damia or the matter. The second part is giving 4 muscular branches. The third part is giving pick pass as the 6 branches. It's okay, Akshay. It's okay. So here you can see the first part and the second part. So actually in this image, you can further see this was explained also. The first part and the second part is lying in the infratemporal region, but the third part of maxillary artery is in the pterygopalatine fossa. It is traversing in the pterygopalatine fossa. Is it okay? Can we move on to the next MCQ, my dear students? Let's move on to the next MCQ. Okay. So we have done with the 3. Here comes the other one. The blood supply to the teeth of upper and the lower jaw is from which of the following arteries? The option given is superficial, temporal, the lingual, the facial, and the maxillary. So if I have to choose the most correct option here, I will definitely go with maxillary artery. And I'm here to explain you why. Because the reason is maxillary artery again. So that means maxillary artery has become a very important topic for this INICET exam. Another question related to maxillary artery. Yeah. So maxillary artery, which is the terminal branch of ECA and its further branches. So maxillary artery is divided into first part, divided into second part, and divided into third part by the key muscle, that is the lateral pterygoid muscle. So when I am talking about, it's the most difficult, ma'am. No, beta, not difficult. I will explain you. Just try to understand. It's not difficult. Okay, maybe some of you have got confused, but let me explain. Okay, maxillary artery, as I am telling you, it is divided into 3 parts by lateral pterygoid muscle, the key muscle of infratemporal region. So here what happens, we know maxillary artery is giving numerous branches. The first part is giving 5 branches: deep auricular, anterior tympanic, inferior alveolar, middle meningeal artery, and accessory middle meningeal artery. So here, if I talk about the inferior alveolar artery, this is a branch from the first part of maxillary artery, which is giving blood supply to the mandible. So that means it is giving blood supply to the lower teeth or jaws. And if I talk about the posterior superior alveolar artery, the branch, the third part of maxillary artery is giving 6 branches. What is the mnemonic? Pick pass. What is the mnemonic, dear? Pick pass. So posterior superior alveolar, pharyngeal artery, sphenopalatine artery, infraorbital artery, artery to pterygoid canal, So all these branches are given. Also, there is descending palatine artery. So all these branches are from the third part of maxillary artery, in which we have two arteries here. One is the inferior alveolar artery, which is a branch from maxillary artery. The other one is the posterior superior alveolar artery, which is again is giving branch to the maxillary tree. रफ्तार इज टेलिंग एनाटॉमी क्लास बंक करते थे मैम. हाँ, मैं जब पढ़ाती थी तो बोलते थे बहुत वास्ट हो रहा है. इट्स ओके, डोंट थिंक मच नाउ. व्हाटएवर यू हैव सॉल्व, it's good. Okay, so don't worry. So anatomy question, I think it was okay. It was moderate level. It was not so easy and it was not so difficult. It was a moderate level. So inferior alveolar artery, it's a branch of maxillary artery, first part, which is giving blood supply to lower teeth, and the posterior superior alveolar artery, branch of maxillary artery, which gives upper teeth blood supply. So I will go with this as the most correct answer. Why not the other one? Lingual is not the right answer. Lingual is related with the oral mucosa, tongue, sublingual gland, but primarily lingual is giving blood supply to the tongue and also floor of the mouth, but not the both upper and lower teeth. So it will be a wrong answer. Facial artery, absolutely. Facial artery gives superior labile, inferior labile branches. It gives branches lateral nasal and dorsal nasal, and also branches to tonsils and submandibular gland. So it's also wrong option. What about superficial temporal artery, which is primarily giving blood supply to the scalp and the face? So it is also a terminal branch of ECA, and it is mainly giving blood supply to the forehead, cheek, and upper part of the scalp. So this is also wrong. Yes. Okay, so Sobik again has given the right answer. Congratulations, Shruti. You got 4 marks. Okay, so many of the students has given the right answer. One of the student is telling me, ma'am, there was medial pterygoid in the option. Okay, so not this one. I think this one. Okay, this one, if there is medial pterygoid also in the option, then also, my dear students, the neck of mandible is the right answer, because lateral pterygoid is dividing maxillary artery into 3 parts. Okay, so basically, then also our answer is right. Okay. Okay, dear, can we move on to the next? So let's move on to the next option. And the next option is question number 5. Parasympathetic ganglion, topographically associated with the cranial nerve supplying the jaw and the oral cavities, is all except. So again, it becomes an easy one this time. Anatomy question easy as compared to November. So Kanchan is also telling anatomy is easy. So that's a good point. Anatomy is easy. Everyone is finding anatomy easy. So that is again a thumbs up for you all. Yeah, it's a good one. So basically, if I talk about the parasympathetic ganglion of head and neck region, here also, if I have to mark, ciliary ganglion is mainly related not to with the oral cavities and jaws. Rest are the submandibular gland, which is also called as Langelay's ganglion, is related with the secretion of submandibular and sublingual gland. Pterygomandibular ganglion, which is also called as ganglion of hay fever, related with the nasal areas, and also otic ganglion is related with the parotid gland secretion. So here, and also palate is related here. So I will explain one. Ciliary is the right answer. Why? I will tell you. Ciliary ganglion. So actually this is from your notes, and from your notes I have picked a few of the images where you can see we have already talked about the ganglion, and the right answer is ciliary ganglion. So here, if I talk about ciliary ganglion, it was easy. Very good. It is a parasympathetic innervation primarily to the eye muscles and eye areas, and it is not related to the jaw and oral cavity. So ciliary ganglion is the right answer. The submandibular ganglion is also related with submandibular and sublingual gland. Definitely, I have given you this explanation, and it is very crucial for forming saliva, thick secretions. Okay, when remembering about all your Chinese food or mithais or the sweets and all. So you have got so much saliva in your mouth. So where the watery secretion is by the serous secretion of parotid gland, and the mucus secretion is via the secretion of submandibular Langelay's ganglion. Yes, ma'am. It read it from the notes. Yes, you have read already from the notes. Great one. The pterygopalatine ganglion is also called as sphenopalatine ganglion, and it's a one of the most important and largest of the 4 parasympathetic ganglion of head and neck region, and it is mainly related with the lacrimal nasal cavity and palate. So definitely it will be also related in the oral cavity. Otic ganglion, as I told you, it is related with the secretion of parotid gland, and it is related. PG means parotid gland secretion, so it is also related. So we have got ciliary ganglion as the right answer, and most of the student has already marked it right. Let's move on to the next one, because I want many of the MCQs still is there which you have to solve. So let's move on to the next one. The cranial nerve supplying all the teeth of the upper and the lower jaw, means the cranial nerve which is related with the innervation in the upper and the lower jaw area is, whether it is the trigeminal, whether it is the facial, whether it is the trochlear or the vestibulocochlear nerve. So what will be the right answer? This one is the easy one, I think. We know that trigeminal nerve, which is giving one of the mandibular nerve, which is very much involved in the innervation of the upper and the lower jaw areas in the teeth. Yeah, everyone should have marked it as the trigeminal nerve is the right answer. Okay, this time what I'm feeling that maxillary artery has been answered to 2 questions on one topic only. Same way, here also 2 questions from one topic only. Yeah, so Abhay has marked it right. Dr. Shruti has marked it right. So yes, everyone, many of the students has marked it right. Yes, very easy one, because facial can't be the answer because it is mainly innervating the facial muscle of expression. Trochlear nerve can't be the right answer. Why? Because it is giving innervation to superior oblique muscle. And vestibulocochlear nerve can't be the right answer because it is mainly for the auditory, hearing and balance sensation. Yes. So this is again from the notes, and in the notes we have already talked about the trigeminal nerve in much detail. Cranial nerve I have already explained you in the much detail, and this is the notes also which you have gone through. This was the notes from which was given from Dr. Ashwani sir. You have gone through this, so very good. We have already covered up this. Trigeminal nerve is the correct answer. Facial nerve is not, because it is not innervating teeth. Trochlear nerve, no, because it is not related to the dental roll. It is controlling eye movement, the superior oblique muscle. Vestibulocochlear nerve is for hearing and balance, not giving innervation to the teeth. Is it okay, everyone? So definitely, after this explanation, we are quite sure the right answer will be the trigeminal nerve. Let's move on to the next one, the question number 7. Actually, this was slight confusing one, but I will explain you. Okay, actually proper options also student was not able to give. If you want, you can give me the proper options. The differences between the symphysis menti and the mandibular symphysis are all except. Actually, I feel the question was there. Actually, if I talk about symphysis menti. I will skip it. Raftar is telling my all anatomy questions are right, so no need for explanation, ma'am. Okay, so good. Raftar is telling I can skip anatomy explanations because I have already marked all question right. So, okay, so a great thumbs up goes for Raftar Singh. Yeah, good one, Raftar. So Raftar में सारे questions correct कर लिया है. Okay, very good. So actually, if I talk about symphysis menti, it is made of fibrocartilage is the right answer. I will tell you why. Because yes, Sahil, you are absolutely right. Because actually, this symphysis menti is a very particular kind of joint. It is not having all the features of symphysis. What do you mean by symphysis? All the joints which is lying in the midline in our body. So all the joint which is lying in the midline in our body is called as symphysis. So we have got sacrococcygeal joint, pubic symphysis, all these intervertebral discs. These are the better example of symphysis menti. The odd man out is a better example of symphysis, secondary cartilaginous joint. The odd man out in this case will be symphysis menti because you can see it lies in the midline, joining the two mandibles. Why I will tell you. The symphysis menti is a atypical symphysis. It's unique because it's a bony fusion and not a true joint like other symphysis which is involving cartilage. So it's a bony fusion. It's not a true symphysis and in traditional sense. And if I talk about this, it's very important for you to know that no cartilage is intervening. So in symphysis menti, no cartilage is intervening. So only it's an atypical type of symphysis or secondary cartilaginous joint. So that is the reason we will strike. It's essentially a fusion point, but it is not having the intervening cartilage. So basically, the right answer will be C. And I don't know. The students has given me these options, not all the option, but I think the question is basically wanting you to know whether you are knowing the atypical features of symphysis menti, which make it different from the other kind of symphysis That is the joints in the midline, which is having in between the hyaline cartilage, it's plate of fibrocartilage is there, which is missing here. Okay, mandibular symphysis is a general term for the fusion, and symphysis menti is a Latin word which is interchangeably used for particularly the symphysis menti. Okay, so done with this. Now I will just check with the students. We can go with the next one. So yes, Raftar. Okay, great. Okay, dear. Okay. So actually, synostosis happens after that primary cartilaginous joint. Okay. So I think basically they must be asking about that fusion point only, the fibrocartilage missing in the symphysis menti. Okay. Now the next one is Wharton's duct open into the areas of lingual, oral vestibule, or lingual folds. So basically, oral vestibule is a big term. It's a big term, and we know that Wharton's duct, which is called as submandibular duct. Ma'am, Kanchan, what is asked? And the option was, okay, Kanchan, yes, dear. Okay, yes, dear. Do you want to understand synostosis? Okay. So if I talk about synostosis, it's a process of two separate forming a single. So synostosis means it is like the two, if I talk about synostosis, it's a bony fusion. Okay. So it's a bony fusion which is seen. So basically, it's a general term which is including osseous union between the normally. So if it is option is, let me come to the synostosis. So yes, my dear student, where is that question? Which? So yes, C is telling one of the option was synostosis. So so basically, if we are talking about symphysis menti, it is quite clear that it is not having fibrocartilage. Okay, synostosis is the term which is used for the fusion which happens in the primary cartilaginous joint, which is called as synchondrosis. After like fusion of epiphysis and diaphysis is synchondrosis, but after that bony fusion in adult, it forms synostosis. Same goes with basis sphenoid joint. Okay, so that way also the fibrocartilage wala jo option diya hai, that will be right. Okay, dear. Okay, Kanchan, is it okay about the synostosis? Then also that fibrocartilage becomes the right one. Okay. Okay, let's move on to the next. Okay, I'm seeing your messages also. Yeah, let's move on to the next. Okay, so yes, lingual fold, lingual, like think is associated. Okay, so what you are telling, there was one option as lingual carangle. Okay, just a minute. Lingual. Okay, if this was an option. So actually, if I talk about lingual caruncles, is a fleshy bump on either side of ferulum. And actually, it is marked the point where the duct of sublingual and submandibular gland opens. Okay. So yes, lingual, if, let me just check the students. Okay, here lingual caruncle. So yes, if there is particularly lingual caruncle in the option, then it will be correct. If it was not, then lingual fold is correct. Is it okay? If lingual caruncle is there, that means it is specifically marking you the bony bump. It is actually sublingual caruncle will be the better word. So if the option was sublingual caruncle, then we will mark sublingual caruncle as the right answer. And if it was not, then we will mark lingual fold. Okay. See here. So this is the opening of the sublingual papillae, opening of the submandibular duct, and opening of the sublingual ducts here. So sublingual area is there. Actually, what option I got, there was no sublingual caruncle is there. There was no, students didn't tell me about that. So a sublingual caruncle is a projection and it is considered the part of lingual fold, where is the significance is that where the so actually marks the point where the duct from sublingual and submandibular salivary gland duct opens or empties in the oral cavity. Is it okay, everyone? Yes. So yes, sublingual will be correct. Sublingual or lingual fold can be correct, but exactly that sublingual caruncle is given, then that will be the more correct answer. So in that case, we will go with sublingual caruncle as the most correct answer. Okay. So actually, it's a very important area, and the function and significance is salivary gland opening is marked, as you can see. So if sublingual fold is there, then that is also correct. So basically, if they are just actually if sublingual fold is there and no caruncle, so we can go with the sublingual fold as the right answer. And if sublingual caruncle is there, then that will be the better option. Is it okay? Let's move on to the next. So has everyone got that point? Oropharyngeal isthmus. No, if the option is oropharyngeal isthmus, that is not correct. So oropharyngeal isthmus will not be correct. Will not be correct. Now, all of the muscles of mastications are elevators of the mandible, except I think you must have marked it right. All of the muscles of mastication is elevating except the one. I think many times your everyone must have marked it right. Okay, everyone must has marked it right. So yes, so okay, all the muscles are mastications are elevators of mandible except. So we know that if we go with the action of the muscle, only lateral pterygoid is the muscle which is depressing the mandible. That means it is opening the mandible. Opening the mandible. All other muscle, masseters, medial and temporalis are elevating the mandible. So most easy one. Everyone must have. Everyone is telling, ma'am, it was lollipop question. Everyone is telling, ma'am, it was lollipop question. Okay, very good. So good one. We have explained it number of times. Notes also I am showing you that so many times I have explained this. So nothing new in this. Okay, this is another question in which it feels that two answers can be correct, but one has to mark most correct because they have typically written third molar tooth. They have typically written third molar tooth. Okay, while extraction of mandibular third molar tooth, the surgeon should be careful about these nerves: inferior alveolar, lingual, and mental. Okay, so few students. So yes, don't feel everyone has marked and done good. So please don't get disheartened if any question is wrong also. Okay, fluorescence, kanchan, everyone. Okay, so nothing to worry. Sometimes easy question also. If some students are feeling that it is very, very easy, like some words they are using, it's okay. It's okay. It's good that many of the student has got all the anatomy question correct. Some has got few wrong. So nothing to get disheartened here. Okay. Yes, Raftar. I'm not going to leave any questions. I'm going to explain each one of it. Yes. So while extracting of mandibular third molar tooth, the surgeon will be careful about these nerves. So which is the right answer here? So actually, both inferior alveolar and lingual is very close to each other, related with the oral cavity and the mandibular tooth. But if I have to go, I will go with lingual as the right answer. Let's see. Lingual nerve is very much close proximity, lying very close to the third molar teeth, and it's critical relation, and this helps the surgeons. So whenever they are performing any of the activity or surgical procedure which has to be done and near to the third molar tooth, we have to keep this in mind that we have to manipulate it correctly, because the branch of trigeminal mandibular lingual nerve can be injured. So here you can see this is the lingual and this is inferior alveolar nerve. So you can see inferior alveolar nerve is going into the mandibular foramen, mandibular canal, and then its mental branch come out, which can be injured if the surgical option is done at the near this midline incisor teeth and all, and midline teeth. But if I have to go lingual, you can see this is exactly the wisdom teeth, third molar, and the most correct will be lingual. Okay, so lingual now. So during the third molar extraction, so the both inferior alveolar and lingual nerve should be paid attention, but more in vicinity. Mental foramen के close में mental nerve injured हो सकता है, but अगर most important in this vicinity, the answer will be lingual nerve. Lingual nerve. Is it okay? So we have done with this. Inferior alveolar nerve can be injured, but if it is more numbness in the lips and chins, but third molar tooth extraction, lingual nerve is the better one. Okay, guys. So all the best, and we will proceed with the next teacher, next faculties, who is will discuss all the MCQs related to their subject. Best of luck. And the MCQ related to anatomy was moderate level. All the best, and I hope everybody should get through this examination. My blessings to you, all of you. So I should like to end now. Is it okay? Okay, dear. So I would like to end now. Thank you. Thank you. God bless you. Best of luck, dear. The result will be okay. Don't take tension. Everything will be fine. Have faith in yourself. So I would like to end now. Okay.
Hello, friends. Hello, friends. Good evening, everyone. Today was our exam, very important day for all of us. This is Dr. Aishvarya Kaushik. I'm your faculty for dental materials, endo and cons. Now, if I combine endo, cons, and dental materials, we have a total of 39 to 41 questions. Why am I saying a range? Because I feel a couple of questions are overlapping in terms of cardiology, are overlapping with pediatric dentistry and community dentistry, although I've jotted them down. As and when they come, we'll of course discuss the question, but if it's completely pertaining to the domain of community dentistry and pediatric dentistry, I would leave it to the wisdom of my able colleagues to discuss them with you. In case of any doubt or any conflict, we can always overlap, or confusion, we'll always stay connected, right, guys? So let's start with the first question. First of all, yes, a tough paper, tricky paper. As you will realize as we discuss this paper, tricky paper. On the face of it appears relatively simple, but quite a tricky paper. So first question, photo curable material cured with laser and put into two-dimensional sections and put one on top of each other as layers. How do you classify this? Extremely difficult. Why? Because of the simple fact that this is an absolute memory-based question, no logic. If you see the options, all the four options are pertaining to some technique of 3D printing. Now, as far as specifically the language of this question concerned, most accurate recall in those terms wherein I've tried to capture the exact sentence without any other irrelevant addition or deletion, because that would completely change the answer. So photocurable material, which is being cured. Okay. Photocurable material which is being cured with laser and put into two-dimensional sections, into layers, one on top of each other, is your stereolithography. That's the answer. I would slightly reduce this size so that it doesn't overlap here. So our answer is stereolithography. Now, if you see the other options, no harm in knowing about other options: binder jetting, material jetting, material extrusion, they are also just like stereolithography, 3D printing techniques only. So binder jetting is an additive manufacturing process where a liquid binder is selectively deposited onto a powder bed. So these terms are not there. Liquid binder, powder bed. So binder jetting is not the answer. Material jetting, again, additive manufacturing, 3D printing, created by selectively depositing liquid material droplets layer by layer. So liquid material droplet was not there in the option. The process which we are describing here, the exact terms, photocurable, resin, cured by laser, two dimensions stacked upon each other as layers, is stereolithography. If you talk about material extrusion, then its synonym is fused deposition modeling. If you remember the recall of INI November 2024, this was one of the options. It seems that 3D printing this way or that way is one of the favorites of INI people. Anyways, material extrusion, also known as fusion deposition modeling, FDM, is again a 3D printing process where a continuous filament of material is melted and deposited layer by layer. So again, you have a continuous filament which would become a key term here. Unfortunately, all memory based. One has to memorize this. Next question, tricky one. Preferred material for perforation repair under composite restoration. Let's get this in perspective. You're doing a root canal, you have a perforation. You're choosing composite as the definitive restoration of choice. Now you want to repair the perforation. Now the examiner is not wanting us to know whether it's a furcal perforation, it's perforation on some coronal third of the root, labial wall, size of perforation, site of perforation, timing of repair, nothing. Simple, straightforward question. You want to do bonding. You want to do etching. You want to apply a bonding agent. Of course, you don't have enamel there, you have dentine. So you're doing a wet bonding technique, right? You don't want your collagen fibrils to collapse, and then you want to cure composite over it. Simple question. Just tell what is the preferred perforation repair material for composite on which it can be stacked and cured incrementally. So first of all, what are the options? DFDP, DFDB, super EBA. EBA is ethoxybenzoic acid, calcium sulfate cola coat. And this question is from Ingle 7th edition. Calcium sulfate is the material of choice, and that's the answer. Cola coat is contraindicated. Why? Cola coat is collagen. If I'm to pack collagen into my perforation defect, collagen has this, it acts like a sponge and it absorbs all the moisture. You don't get a dry field. If you don't get a dry field, how are you going to do bonding? Right? So I've taken screenshots from our textbook of endodontics by Ingle. If you see collagen barriers, good for achieving hemostasis, but the problem is cola coat is contraindicated as a barrier if addition dentistry is contemplated. So addition dentistry is composite restoration. Calcium sulfate is the barrier of choice when utilizing the principles of wet bonding. So we're dealing with wet bonding basically is you're doing a composite restoration. And calcium sulfate is the material of choice. We have got used to dealing with all these questions as one single answer MTA. This was a new one straight from our standard text. It's a very simple question. Next question. Always do this in my class, silane coupling agent. What do you do? What is its function as a component of the composite material? You just know it. What is silane coupling agent? Gamma methacryl oxypropyl trimethoxysilane. On the one hand, it's going to chemically bond with the silica filler, and on the other hand, it's going to chemically bond with the carbon-carbon double bond of the methacrylate, essentially forming a true chemical bond between the two so that you don't have any weak line of fusion. A simple question, binding the resin to the filler. That's as straightforward as can be. The rest of the options did not make any sense. Simple. Which of the following, a tough one now, again, image-based question. Now, how does the image look like here? You have, the question was very interesting. The question goes like, for a composite restoration preparation, we have been given an image, right, in which we have these two cusps of a premolar, or if you see it in a proximal section, it can be a molar also, but classically a premolar. And you have a proper thickness of enamel here. And then you have dentine. So that's your enamel. Enamel rod direction is given. Enamel rod direction is given here, which is converging towards the occlusal pit and fissure, diverging towards the proximal surface and very near to the CEJ. As it approaches, it goes parallel, right? Another important thing, the tooth was kind of tilted. It's like a mandibular premolar or a mandibular first molar lingually tilted. So you all know, in order to ensure that you have adequate support of dentine for the enamel, you're supposed to tilt your burr along with the natural tilt of the crown, right? So one preparation wall that was shown, if all of you recall, was something like this, right? Slightly converging, but not as converging as not exactly straight, slightly converging, which is well supported by subsequently larger enamel rods. So it is the strongest enamel margin. This was labeled as A. Yes. This is labeled as A. So this was a slight converging. So A was slight converging external preparation wall that you made with your burr. Then B was very near to your cervical area of the tooth and exactly parallel to the enamel rod. So that was B. Right? Now, friends, according to Sturdivant, if you talk about the occlusal portion, like a class 1, or the occlusal step of a class 2, the preparation is slightly converging for a composite prep, for a conventional composite prep, not a modified, conventional composite prep, just like that of amalgam. You don't want to give a B-well on the occlusal surface because the composite is not as strong in a thin section. So A is perfectly right. What about B? Now B, if you see this image very clearly, it's a buccolingual section. It's a buccolingual section. It's not a mesiodistal section. A mesiodistal section in the image would be like this. It would have a big, representing the mesiodistal dimension of the occlusal form, but the buccolingual section represents your buccal and palatal or lingual cusp. So what do we mean? If I make a preparation wall here, then this is like a mesiodistal section represents that this is a gingival seat, whereas a buccolingual section represents that this is either the facial wall or the lingual wall. Now you'll ask me, what is the difference? The difference is that for a composite prep, your class 2 gingival seat is more or less following the enamel rods. You do not need to bevel it, right? But when you're dealing with a class 5 lesion, this is a situation in which we are dealing with a class 5 lesion, right? Then this should be beveled if it is on the crown surface. If obviously your gingival wall is apical to the CEJ, then there is no bevel in a composite prep. But if this is in the coronal to the CEJ, this wall should be beveled, so as to increase the surface area, get good micromechanical retention, and so on and so forth. Yes, so this was a trick question in which the examiner is giving you a buccolingual section of the premolar, giving you this proximal view. So this is the diagram which actually came, not the mesiodistal section, but the buccolingual section. So the occlusal portion is fine. So A is correct. B should have been beveled. In the exam, B was parallel to the enamel rod. And the prep, if I remember correctly, the prep was coronal to the CEJ. It was not on the root surface. And the prep was parallel to the enamel rods. You can raise your doubts in case you have a different version of recall. But if I remember correctly, the prep on the smooth surface was, just seeing the chat box here. Yeah. Yes, beta. No, Florence, A is right. A is right. Your wall is always converging, and there is no bevel on the occlusal portion. B, I think B should be beveled. So B is wrong. So according to me, A is right, B is wrong. That's the answer. Of course, the exam had, we had, the options were both A and B are correct, both A and B are wrong, A is right, B is wrong. So I would go with yeah. This is not A and B. This is the information that I've written as part of the question. And this is option A, this is option B, right? Option C would be A is right, B is wrong, and that's my answer. D is A is wrong, B is right. Right, guys? So my answer is A is right, B is wrong, right? Again, trick question. You guys, you have to orient yourself to the diagram, whether it's the buccolingual section, is the buccolingual that you're seeing, or it's the mesiodistal. The buccolingual is always compressed because the buccal and lingual cusps and very little tooth structure in between. Mesiodistal is, tooth is slightly longer, isn't it? All right, there was this question. This is just discussed. This is being done by our PCD faculty, so she'll take care of this. That there's an adult patient who's categorized as moderate caries risk. Which of these should not be recommended to him? Right? The options were recommending a sugar substitute, OTC, over-the-counter fluoride rinse, fluoride varnish application at every recall 6 months, do routine checkup at every 6 months, and do oral prophylaxis. I leave this question and answer to the wisdom of our PCD faculty, right? Okay, good question, guys. Image-based question. After Florence, I do not, no comments yet. Anyways, no worries. Okay, guys, very important question. This is based on ICDAS, right? What was the image like? It is an image-based question. You had an upper molar. Again, you have to be very careful while understanding these questions. Upper molar, the image showed proper discolored but not exposed, discolored entire fissure, occlusal fissure, dark brown to black, discolored. Also, on one of the cusps here, this cusp, right? One of the cusps here, there was a dark bluish discoloration representing undermining caries, right? And they had asked us, how do you classify this caries according to ICDAS, International Caries Assessment and Caries Assessment Classification, right? The options were ICDAS 2, ICDAS 3, ICDAS 4, and ICDAS 5, right? The answer here is, guys, ICDAS 4. How do we reach that answer, guys? So see here, ICDAS is a dark shadow on the underlying dentine. Very clearly, we had a dark shadow on the underlying dentine. If you remember correctly the image, yes, the pit, the entire fissure, occlusal fissure was discolored, but there was no discontinuity. You could not see dentine underneath. Even if you had seen, then also, if less than half of the tooth structure was involved, then also, the answer would vary. So very trick question. You were not able to see dentine underneath, but we were able to see dark shadow on the underlying dentine. And the occlusal pit and fissure, the entire fissure was discolored, but no visible dentine. So the answer is score 4. So I'm going with score 4 here. There was actually another question, 2 more questions regarding ICDAS. One was actually overlapping with pediatric dentistry, isn't it? 8.5, the 4th quadrant of a child of the deciduous second molar. It was an image-based question in which clinical image was also there and radiograph was also there. We'll discuss that also, just for the sake of completion, right? Yes, what are you guys saying? Recalled 6 months is correct. Konsa beta 6 month? Which one? Anyways, you can elaborate on this. All right, guys, great. So the answer here is ICDAS 4. So we had a upper molar stained, entire fissure stained dark brown, gray discoloration or grayish, or you can say bluish tinge on the, on the dentine, representative of undermining caries. So that's ICDAS 4. Okay, very simple question based on ICDAS only, which is best for caries assessment on a scale of 0 to 6. We all know this. 0 to 6 is ICDAS. So the answer is ICDAS, right? Always good to remember these 0, 1, 2, 3, 4, 5, 6. As you realize in our today's exam, beta. Yes, total 3 questions on ICDAS. Dear, I don't want to create any confusion with our that moderate risk question. I just discussed that our community faculty is taking. So let us go with just one answer. Still, if there is any doubt or conflict, I'll talk with her and then we'll finalize that, right? Because we don't want any overlap. Otherwise, we end up having more questions in our database, right? So don't worry. That recall will be done, I think, tomorrow only. So don't worry. All right, great. Simple. You had an X-ray. Yes. And the X-ray was an IOPA in which lower incisors were there with periapical pathology. So I think Dr. Dag or Stewick gave the periapical index. So how do you classify that? Based on which scientist, which classification, or Stewick? So that was the answer. Correct me if I'm wrong here. Right? So Dag or Stewick is the answer. Beta, I do not think visible dentine was there in that question. ICDS, the visible dentine would be, well, let's Kanchan, let's see other people's views also. If there is a conflict there, we'll check what other people have to say. But I feel what I recall is that there was proper discoloration of the entire fissure. And I don't recall any visible exposed underlying dentine with a milky white color. I don't recall that. Anyways. All right. Then another another important question. There was an IOP X-ray of upper central incisors. And they asked us about upper left incisor in which replacement resorption was taking place. The IOPA was not exactly this. It was here, as you can see here, all kind of replacement resorption is taking place, but the IOPA was more, relatively more easy. The entire middle third to the apical third of the root was kind of gone and it was replaced with normal bony trabeculae. The options that you had were external inflammatory root resorption, internal inflammatory root resorption, external replacement root resorption, and you also had this invasive resorption. Now, this is a classic, if you see the pathogenesis, obviously, replacement of the root has taken place by the bone, where normal bone remodeling has replaced the root dentine. And you can see trabeculae in place of the root which was there, right? So the answer, no doubt, is external replacement resorption. There is no doubt. This is a simple radiographic diagnosis question. A related question to this, which causes a lot of confusion, is which is the most common type of resorption that takes place following the avulsion injury or following replantation of an avulsed tooth. Now there, the answer becomes external inflammatory root resorption. Now you'll ask me, sir, why? There also eventually replacement resorption will take place. Yes, that's true. But the pathogenesis is that first inflammation will take place. And that inflammation leads to the bone taking over, the bone remodeling taking over, and then replacing the dentine. Because in severe trauma, what happens is that PDL is gone, PDL is necrosed, right? So what happens? When repair takes place, instead of fibroblasts coming from the PDL and, replacing dentine, what happens? Bone precursor cells come from the surrounding bone and they replace dentine with bone, right? So first inflammation takes place, and then obviously as a result of that, replacement resorption takes place. So if you get a question in which is the most common type of resorption following a traumatic dental injury, then it's external inflammatory resorption. Yes, it does lead to external replacement resorption in avulsion cases. So there the answer becomes based on the start of pathogenesis. Here, it's a simple radiographic diagnosis in which you can clearly see that replacement resorption is taking place. Next question. Now, this is an image-based question. Again, a tricky one. Image-based question. The child fell down. The tooth got avulsed. Which one? 1-1. So very clear the examiner was that this was 1-1. The other information that the examiner gave us, that it's an open apex or an immature apex tooth. The child is 12 years old. Now, you don't have to apply your head here that, okay, his upper central incisor must have erupted when he was 6. So it's almost 6 years. Now, it must be a closed apex. The examiner is telling you that it's an immature apex, and the examiner is not saying that this was a necrotic tooth beforehand. So if that information is not given, see guys, 6 years is the ideal time. But eventually, if you realize that it's almost many a times by 7.5 years that the upper central incisor comes. That's one. Second, there's a range of root end completion, 3 to 5 years. It's not like the child is 6, the tooth will come, and by the +3 years, when he's 9, the root apex will finish, will be completely formed. That's not the case in clinical situation. The tooth comes by 7.5, and it may take up to 3 to 5 years for the root end formation to complete. So you don't have to jump the gun. You don't have to second guess the examiner. The examiner is clearly saying this was a normal tooth. He's not mentioned that, but he's not saying that the tooth was erstwhile necrotic or something like that. Simply saying it's a 1-1. The child is 12 years old. It's an open apex, immature apex tooth. He fell down, and very soon thereafter, he himself, the child, the 12-year-old child, had the knowledge, he himself replanted it back. And within 45 minutes, in the next 45 minutes, he also had guidance that he went to the dental clinic. He went to see his doctor. That is the information given in the exam. Nothing more, nothing less. So immature apex tooth, 1-1, 12-year-old child, re-implanted it back soon after the injury, that is soon after the avulsion. And then within the next 45 minutes, he has reported to the dental clinic. So what do? He managed his PDL very well. Very soon means if nothing else is mentioned. So ideal situation, within 15 to 20 minutes, he reimplanted it back. So the PDL, great going. We are not expecting necrosis of the PDL. Number one. Number two, also, if it's an open apex case, and if you reimplant it back within the first 1 hour, you give the tooth a chance for revascularization. So eventually, what do? You clean the area. As a doctor, what do? You clean the area, number one. You suture gingival lacerations, if any. You take an IOPA X-ray to basically confirm the correct position of the tooth. And you do splinting. In the exam, it was given wire and composite splint. You can do titanium trauma splint. Basically, the splint should be a functional splint or a semi-rigid splint for 1 to 2 weeks. That's what you're going to do. Nothing more, nothing less. The other options were all big, take the tooth out in your hand, do apexification, so on and so forth, scrape the tooth of its PDL by dipping it in sodium fluoride for so and so minutes, nothing doing. Simple, straightforward answer. This is that type of question wherein you read the question correctly, understand the order of things that are happening as they happened, as the examiner has told you, and make a mental picture of the treatment plan. before looking at the options. Then when you reach when you reach your answer, your logical answer, then you match the most appropriate option and you have the right answer. Nothing doing other. Rest of the options were all this thing, right? Wonderful. Yeah. Next question, image-based question. This is actually a pediatric dentistry question, but again, based on IGDAS, so I would take the liberty of discussing this with you. Image-based question, you had two images. One was a clinical image in which you had, the third and the fourth quadrant. So in pediatric dentistry terms, it would be 7 and 8, right? 5, 6, 7, 8. So they asked us about the IGDAS classification, ICDAS classification of 8, 5, meaning the fourth quadrant, second deciduous molar. The clinical image is showing the entire occlusal surface being carious and grossly decayed. The X-ray is showing that this caries is communicating with the pulp, with the carious exposure. Obviously, it's the most severe form. It's ICDAS 6. The options were here, ICDAS. What were the A, B, C, D options? ICDAS 3, 4, 5, and 6. So what's the answer? ICDAS 6. IGDAS 6. Why? What is the classification for 6? Extensive cavity evident in dentine. Cavity deep and wide involves more than half of the tooth. Deep, wide, deep because it's exposing the pulp. Wide, entire occlusal surface is involved. More than half of the tooth, practically the entire tooth was involved. So ICDAS 6. Of course, it's a pedo question, but yeah, I took the liberty of discussing it here. Okay, another important question with multiple options as correct or wrong, whatever the case may be. So the examiners asked us the beta titanium or titanium molybdenum alloy as compared with stainless steel. Which of the following are true? So again, without looking at the options, whatever your knowledge is there, for example, as we've always discussed in our lectures, if you see this table, this master table, the beta titanium has got the modulus of elasticity somewhere intermediate. The examiner, of course, does not mention intermediate between what? What he basically meant was intermediate between stainless steel and say NITI, somewhere there, right? That makes sense, although that information was incomplete in the exam. But yes, intermediate between SS and NITI. Of course, SS is elastic modulus is very high, 179 gigapascal. NITI is very low, 41, and beta titanium is 72. So yes, this takes care of two options. Higher modulus of elasticity, that's a wrong statement because it has got lower than SS. Intermediate stiffness, yes. Stiffness is what? Stiffness is a measure of modulus of elasticity only. So this is a correct option. Another important point is that because of its titanium content, it's very highly corrosion resistant. So option C is right, option E is right. Is it weldable? Yes, it's pretty highly weldable. That's also another important question. And its formability is also high. So if you see here, formability of TMA is greater formability as compared to SS. So this also is right. Beta titanium's true weldability. They are the only orthodontic wires which show true weldability. So they are also very weldable. Good corrosion resistance. Excellent corrosion resistance. Yes. Because of its titanium content, their biocompatibility is also very good because they are nickel free. And surface roughness was not asked. I just added it here that TMA has got very high surface roughness. And from this table, we realize that its stiffness is somewhere intermediate. So what are the correct options here? B, C, D, and E. So we had to mark that option. We had got various permutations and combinations, A, B, C, D, E, B, C, D, E, and so on and so forth. So the only wrong statement here is it has a higher modulus of elasticity. The rest of the statements regarding TMA are correct. Beta Ridhiman, RCT, we do not have to start in that case of immature apex. We only have to start RCT if revascularization does not take place. Here we are giving a chance for natural revascularization because it's an open apex case and the child was so intelligent that he immediately put it back. If the extraoral dry time is more than 1 hour, then only we do extraoral or apexification within 7 to 10 days. Beta formability was not in the option with weldable. Acha, formability. Okay. Okay. So you mean to say the options? Was that true? Okay. So then I would go with weldable over higher formability. Then I would go with, if I have to choose between these two, then I would go with weldable. Because it's the truly weldable material. Right? Okay. Another trick question. Out of the 4 options, 2 made sense, 2 did not. So the confusion was between these two. Obturation of root canal is done to prevent. One was seepage of fluids from lateral and accessory canals into the root canal. Second is colonization of bacteria in the remaining empty spaces and fluids. These two make sense. So we've done cleaning and shaping. Why do we need to obturate the root canal? Our aim is to get a hermetic seal, that's an airtight seal, that's not possible. The second best aim is fluid impervious or fluid tight seal. See, if you don't obturate, what's going to happen is from the surrounding periapical tissues, from the leaking canal, because if you don't obturate from the main canal, accessory, lateral, tissue fluids will come in. They're full of glycoproteins. Whatever remaining bacteria are entombed, they would colonize. So actually both options are correct. But in the order, what is the most important, first important thing where you just stop the chance of any bacterial colonization? Prevention of seepage of fluids. Therefore, that is my answer. The seepage of fluids from lateral and accessory canals is, according to me, a better answer than colonization of bacteria. Ultimately, that is our aim. But doing obturation to prevent seepage of fluids. This is simple, which is not true. Regarding periapical curettage, you basically do curettage, you scrape off the granulation tissue. That helps you in deloading, the size of your periapical tissue, decreasing the bleeding because the granulation tissue bleeds a lot. You remove it, you get better accessibility, visibility for further apicectomy. What curettage does not imply is that it does not deal with complete excision of the periapical lesion or the cyst. So that's not true. So entire lesion must be removed. Is that the definition of periapical curettage? Absolutely not. That's cyst denucleation and then apicectomy, right? So that's the false statement. This is a simple question. Beta consa D was not in the option. I'll come back there. D. Which one is D? Higher formability. So we don't go with that, no. Then we go with B, C, and E. In this question, Ridhiman, if D was not, then we go with B, C, and E as the best answer, right? Okay, trick question again. Pulp removal in cervical pulpotomy for anterior tooth. If you remember, anterior tooth was mentioned. So we are dealing with a possible traumatic dental injury, right? In fact, if I remember correctly, the examiner also mentioned a traumatic dental injury, right? And your specified anterior tooth that I clearly remember. So if you're doing a full pulpotomy, cervical pulpotomy, that is a full pulpotomy. So the options was poor excavator, diamond burr, stainless steel burr, and carbide burr. All of us remember our pediatric dentistry, right? in which you're dealing with pulpotomy, full pulpotomy of carious exposure of a primary molar. Classic diagram, you use a big, large size spoon excavator. Here there is a catch. You're dealing with an anterior tooth, which is possibly, in all likelihood, even if not mentioned, don't exactly remember. What I clearly remember is that he's talking about an anterior tooth. He's talking about full pulpotomy or cervical pulpotomy. And I think traumatic dental injury was mentioned, that the cause of pulp exposure was a TDI, and the pulp removal and cervical pulpotomy is decided as the plan of action of the treatment plan. Now, very clearly in Cohen, very clearly it writes that the technique of the removal of the pulp for cervical or full pulpotomy is the same as that in partial pulpotomy or Schweck pulpotomy. And what is that? High-speed diamond burr. Right. So here the answer will not be a spoon excavator. The answer would be a diamond burr. Yes. This is a screenshot that I've taken from your Cohen. Partial pulpotomy technique. We use a high-speed handpiece with sterile diamond burr. And when you talk about the full pulpotomy and the technique, you clearly remember the coronal pulp is removed as in partial pulpotomy, but to the level of the root orifice. So the technique remains the same, the level changes. So using a sterile diamond burr. Yes, if it would have been mentioned full pulpotomy for a carious exposed primary molar, then you can do it with a burr, but classical technique is a big, large size spoon excavator, right? Simple question. Next question. Most complex root canal morphology? Mandibular second molar, C-shaped. Simple. Next question, very simple. Always do this in my lectures. The phase of amalgam most susceptible to corrosion, responsible for its own breakdown is your gamma 2. That's your tin mercury phase, right? SN78 Hg mercury. So that's your gamma 2. These are some of the simple questions. Okay. Now, this again is, I think, being covered with community dentistry, just for your knowledge. I thought it is related to karyology, so which is true for nano silver fluoride solution as compared with silver diamine fluoride. Now, obviously, I'll go with whatever our community and pediatric dentistry faculty says, but according to me, high caries arrest rate as well as does not discolor tooth, both are correct. Both are right. Let's see what our pediatric dentistry and community faculty says. Again, this is also, I'm leaving with our community. This is a classic community dentistry and pediatric dentistry question regarding 38% HDF. Okay. Most efficient method of removing gutta percha in a retreatment case. Straight pick from Engel. It is the rotary method, guys. So, rotary method. Engel, rotary instrumentation, this is the screenshot from our 7th edition Engel, is the most efficient method for removing GP from a previously treated canal. Right? Okay. Dr. Rupinder is saying that in that question of there was shadow from dentine. Yes, there was shadow. Dear Rupinder, there was a shadow, underlying shadow of dentine, but it was not exposed. There was a bluish discoloration which was representative of undermining caries. That's why ICDS 4. If there would have been break in the continuity and you could have seen underlying dentine, not the shadow, but the dentine. I mean, that's what I remember. Then it would have been ICDS 5. And the answer totally changes. So let's keep on discussing and arguing about this, because that's what my recall is. I might be wrong there. Let's see. Let's see how this develops. I'll ask 2, 3, 4 more people about this. Okay, simple question, guys. Difference between addition silicone, that is PVS, polyvinyl siloxane, and condensation silicone? No byproduct. No reaction byproduct in the setting reaction for PVS. Simple. Very simple. Disadvantage of polyether in undercut areas. It has the highest stiffness. So it will loosen the tooth, or a mobile tooth, it will extract the tooth. Isn't it? It will be very difficult for it to be removed because it will not be elastically deformed easily. This is something that we always do in my lectures here. That's a screenshot wherein I'm discussing the order of stiffness. Isn't it? As simple, guys. Okay, again, a simple question. So few simple were also there, thankfully. Yes. Devender, loosely condensed. Beta loosely condensed भी होगा ना Dr. Devender. Then also, what do you think? Then also rotary would be there, no? I mean, rotary would be faster than an H file, right? If at all you're thinking about H file. Because Engel does not differentiate between loosely or well condensed GP, isn't it? See, that's my statement. Where is my statement? Where is it? For removing gatta parcha, rotary instrumentation is the most efficient method for removing gatta parcha from a previously treated root canal. And obviously, needless to say, when you have to do retreatment, many cases will have loosely condensed GP only. But that won't change the answer. Rotary instrumentation becomes the most efficient method. Efficient. What do you mean by efficient? In terms of time, it takes less time. No bearing whatsoever on the success rate. If I am someone who's preferring H file to remove my GP, I might take more time. I'll be less efficient. But my success rate of my retreatment won't depend on whether I've used rotary or H file. Understand? Okay, is that fine? Yes, Dr. Devendra, I hope you got that. As I just said, H file is there, but it is not the most efficient method, irrespective of whether GP is loosely compacted or well compacted. All right, great. This is again simple question, guys. Manufacturers make normal set alginate as well as fast set alginate. So what is the difference due to? I mean, you have the retarder, isn't it? You have other components like calcium sulfate, that's the reactor. You have diatomaceous, that's like a filler. Potassium titanium fluoride is giving you that strength of your gypsum when it is poured. If you remember, we always discuss this, the entire composition. Sodium phosphate is the retarder, isn't it? It will first react with the alginate salt, sodium, potassium, or triethanolamine alginate. First, the entire sodium phosphate will be used up. Then, when the sodium phosphate is used up, then the alginate would react with calcium sulfate to form calcium alginate to give you the set product. So, when you play around with the content of sodium phosphate, less or more, if it's less, be a faster setting. If it's more, normal set, right? So the answer is sodium phosphate. Simple logical question. Again, this is actually a repeat question, but tough one. Image-based question, again, a buccolingual section of premolar. They have shown you enamel caries and dentine caries, and underneath that, a proper white block of tissue which is devoid of any tubules, dentinal tubules, right? And very near to the pulp horn. So how was this was the image that actually came, right, guys? So let's analyze this. They had shown this like this, right? This is the bacterial plaque, as you can see here from the labeling. This is from Sturdivant. Then there was a darkish discoloration around that is representative of the caries, right? So you have the outer carious dentine, then you had the turbid layer, and what they marked as the question was this white block. Which one? This one, guys. This white block. Am I clear? Okay, just a sec. They had asked about this block. Can you see this one? Can you see the yes, this one, this white block? Yes, underneath the turbid layer. That was the question. Very tricky question. It's actually a repeat of INI November, but I'm sure still, despite the repeat, many of you would have done it wrong. Tricky question. The options were reparative dentine, yes, firm dentine, soft dentine, and what was the other option, guys? Secondary dentine. How many of you have marked reparative? It was not reparative, guys. Reparative is even underneath, lining the pulp. Yes, this block was very close to the pulp bond here. It was like this, isn't it? I'll make this again with a thinner section. Here, dekho. This is what they asked, isn't it? Here, dekho, this block of white. Right? This, they have asked transparent layer. And if you read Sturdivant, this transparent layer is soft because it has got demineralized hydroxyapatite. Inorganic layer is demineralized, but it has got collagen where cross banding is still present and it can remineralize. So it's soft, but if you manage the caries well and you create conducive conditions, it will again remineralize. So this is what they asked. Not reparative dentine. It is soft dentine, which is the answer. Soft dentine is the answer, guys. This is a question which is going to differentiate a ranker from, a bit of firm nahi hai na. This is soft dentine. Rupinder, this is not firm. Yes, beta, Nikhil, exactly. It's affected. It's part of affected dentine. Yes. So affected is transparent and subtransparent. Yes. Okay, a tough one. But, I did this in the recall of INI November also. And if you guys have done this wrong, guys, I always say this, PYQ, 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 PYQ. And it's there. The database is there with you. The video is there with you. In fact, it's freely available on YouTube. My PYQ session, my recall session in INI November. It's a straight repeat. But I know, despite this being a straight repeat, it's a tough one. Yes. Material that releases calcium and stimulates reparative dentinogenesis. This is simple, guys. This is MTA. Straight pick from your Ingle. This straight commonsensical question. This is a screenshot from Ingle. On a cellular level, MTA promotes hard tissue formation. It slow calcium release is seen, alkaline pH of 12.5, so on and so forth. Reason for micro leakage in resin-based composites, simple, guys. Polymerization shrinkage, that's not given in the options. Next best answer, mismatch in coefficient of thermal expansion between the tooth and composite. Right, so that will create a gap, that will cause micro leakage, that will cause secondary caries, discoloration, so on and so forth. According to international guidelines, permanent tooth, closed apex, intrusive injury, 8 mm. Simple, greater than 7 mm, you have to surgically extrude it. You can't wait and watch. You can't do ortho repositioning. The answer is surgical extrusion, retention, and observation. What do you mean by retention? Basically, you give a retainer, or you want to retain it in its position so it doesn't go back. So you basically do a wire and composite splint or something like that. You can apply a splint from canine to canine so that it's not pushed back into the socket, right? So surgical extrusion, retention, and observation is the answer. Simple. Okay. In which traumatic dental injury, okay, applied question, guys. In which traumatic dental injury of teeth with closed apex are antibiotics routinely recommended? Now, the classical thing here is avulsion was not there in the options. You all know in the first appointment, you recommend tetracycline or a penicillin, right? As an antibiotic, right? But avulsion was not there in the option. And in the rest of the traumatic dental injuries, there is no clear-cut description of prescribing antibiotics. So what is the answer? We have to go by logic. So first, let us look at the options. Root fracture was there, intrusive injury, extrusive injury, and lateral luxation. Now, guys, why do you give antibiotic in an avulsion injury? The logic is that the moment a tooth is avulsed, and this we are talking of closed apex, mature apex avulsion injury, the tooth is, it will never revascularize, right? It is bound to be necrotic. Now, a necrotic tooth, if not managed within 3 weeks, will be full of bacterial colonization, right? Will be full of bacterial colonization. Normally, in the first appointment, we manage the PDL. We do splinting. We suture the gingival laceration. So we usually call the patient after 7 to 10 days and then do root canal, right? We know the tooth is necrotic. We know the necrotic pulp is a good substrate for bacterial colonization. So we want to prevent that. And that's why one of the reasons is we give antibiotic. So that bacterial colonization at least doesn't happen in the next 7 to 10 days when we do the second recall or the first recall, the second appointment. So basically the rationale of giving antibiotics is to prevent bacterial colonization of the necrotic root canal. In which other injury apart from avulsion is the tooth, especially, it is clearly mentioned, see the smartness of the examiner, it's mentioned closed apex. So in which traumatic dental injury with a closed apex, apart from avulsion, necrosis almost definitely happens. Intrusions. And that is where antibiotics is going to help us in, again, at least, if not preventing, then at least delaying infection of that necrotic canal so that when the patient comes back in the second appointment and we are able to do pulpectomy of that sterile necrotic pulp instead of an infected pulp, right? So the answer is intrusion injury, guys. Logical question, applied question, right? I've taken a screenshot for the management of avulsion from Cohen, right? So necrotic pulp. So you are basically giving systemic antibiotics. This is from avulsion, because it prevents microbial invasion of the necrotic pulp and therefore subsequent inflammatory resorption. Tetracycline has the additional benefits, so and so on and so forth. So from here, you understand that you're trying to manage a necrotic pulp. That's the main advantage of giving antibiotic in avulsion. And therefore, the same case will be that with intrusion, right? What is the disadvantage of luting GIC while cementing a full crown? Luting GIC, you mix it in a lower powder liquid ratio when you're trying to, when you're using it as a luting cement, and that can cause pulpal damage. So the answer is potential damage to the pulp. Straight pick from your Phillips. GIC elicits a greater pulpal reaction than ZO, and especially luting agents, which pose a greater pulpal hazard than glass ionomer restorations when the GIC is mixed with a low PL ratio because of its acidity and so on and so forth, right? Okay. 63-year-old patient presented with fracture of 5-unit bridge from upper right canine to the upper left lateral incisor, right? The lateral incisor is fractured 3 mm from the gingival margin and is vital. What do you do? Now, guys, first of all, there's a problem here. Why? Because right canine to left lateral, right? So there is a lateral here also, no, in the first quadrant. Now, the examiner is not mentioning which lateral he's talking about. So probably it's the left lateral only. Now, left lateral is the terminal abutment, right? And you just have 3 mm of that left above the gingival margin. That will not be able to sustain that entire bridge, isn't it? Also, it's not mentioning how many teeth are absent. It's kind of an incomplete question, isn't it? So to be on the safe side, I would go with doing a root canal of the lateral, doing a post and core, building it up to some height so that I can make a new bridge, right? So my answer here would be first check LI for ferrule. Obviously, you have adequate ferrule in 3 mm, but again, the problem is if it's a terminal abutment, I would go with devitalizing it intentionally, fabricating a temporary bridge first so that the patient can go home and, doesn't want to go home without a bridge, and then fabricating a post and core. Guys, that is my version. That is my answer. I would still discuss this with my able prostho faculty. If there is any conflict, we'll get back with you. But according to me, if the examiner is so non-specific that he's not mentioning which LI, then I go with the worst scenario, right? That's a LI of the opposite side, right? Not the in-between LI, the LI of the opposite side. Now, if that is so small, 3 mm, although ferrule of 2 to 3 mm is okay, it's pretty okay. But still, I think if you get more length of a terminal abutment, it would be better for the long-term retention of the bridge. It's a 5-unit bridge, right? But still, I would check this with our prostho faculty. In case there is any change, we'll let you know, right? As of now, I think all these steps should be done A, B, C, D. I think all these steps A, B, C, D should be done, right? Okay, not true regarding partial denture alloy regarding a partial denture where the alloy is used, metallic alloy is used as a denture base. So guys, this is simple. Tissue adjustments and relining is easy. This is false, isn't it? If you have an acrylic base, then relining is easy. How are you going to reline a metal, a rigid metal? Right? The rest of the things are fine. Bulk is less. You have better stimulation of the underlying tissues because metal is a good conductor of heat. So you good stimulation of underlying tissues. But tissue adjustments and relining is beta. Invariably. No, beta, I think that question you're saying? No. In which of the traumatic dental injuries do you invariably recommend antibiotics? That was the question, dear. Not endo treatment. Right? In which of the traumatic dental injuries invariably or routinely or invariably do you recommend antibiotics? That was the question. All right? ठीक है रफ्तार सिंह okay. Okay, what does flow mean in relation to alloy base of partial denture? So it basically means that when it is in liquid state, you melt it, how well it flows and how well it captures the wax pattern which you're casting. So the answer would be flow in the liquid state. This flow for the alloy base of partial denture, guys, is not related to sag. So deformation under constant stress or deformation under its own weight or under its own weight or mass is not the answer. This is flow in liquid state. The flow of alloy in a cast partial denture refers to the properties of the alloy, specifically its viscosity and ability to fill a mold during the casting process. Right? Pulp vitality testing refers to. Okay, this is very straightforward, simple. You have to go by the true word meaning. Pulp vitality testing refers to the assessment of characteristics of the pulpal vasculature. Simple, not response of pulp to stimulus. That's pulpal sensitivity or sensibility tests. Pulp vitality tests are an assessment of characteristics of the pulpal vasculature. Right? Then there was this confusing option of measurement of oxygen saturation. That is specifically for pulse oximetry, guys. But pulp vitality involves other techniques also, like cholesterol crystals, like laser Doppler flowmetry, right? So various aspects of pulpal vasculature are there, not just the level of oxygen saturation. So the best answer is, beta, apart from Florence and Devender, anybody else thinks that that question is asking about endo treatment and not routine use or invariably the use of antibiotics in a traumatic? I'm pretty sure it was, but I don't know. I might be wrong, guys. But I mean, Florence and Devender, I think we'll ask this from other friends. बेटा ये ब्रेकआउट रूम में डाल देना. ऑलराइट, ठीक है. Nikesh Maheshwari, which one? What are you going with? I think it was antibiotic use. Can't be wrong there, yaar. I don't think I can be wrong. नहीं, pulpal vasculature था बेटा. All right. Okay, in a child following a traumatic dental injury, the pulp may not respond to pulpal testing due to what? The ideal answer, you know what, in a child is what? The ideal answer is that usually the innervation follows the pulpal vasculature, right? So when you do your routine pulpal testing, like cold test, heat test, EPT, you don't respond. That was not there in the options. So the best answer, second best answer, I think, is the pulp is stunned and is in a state of shock. That is my best answer. Right, beta? Yes, dear. It's sad. Okay, Florence, then let's see. Let's see what what other friends of yours say. Right. हाँ. Beta, ये है ना, this is ideal 30 gauge endo irrigation needle. The answer is simple, isn't it? Side vented and round. Closed ended. It has to be closed ended so that it's not open ended. So it's closed ended and round. That's the answer. This is simple. Ideal 30 gauge endo irrigation needle is closed ended and round. कौन सा बेटा? If endo treatment has been asked. हाँ, प्रवेश, एंडो ट्रीटमेंट अगर करोगे तो इनवेरिएबली आप इंट्रूजन में ही करोगे ना, बिकॉज नेक्रोसिस होगी उसमें. रूट फ्रैक्चर में 25% ऑफ द केसेस अंडरगो पल्पल नेक्रोसिस, सो यू कैन वेट एंड वॉच. Extrusive luxation में pretty good chances that necrosis won't take place. Lateral luxation में more chances that necrosis will take place. So there are more chances that you will have to do endo. But in intrusion injury, of course you're going to do endo. Just like avulsion after 7 to 10 days. That is within the first 2 weeks. Simple है वो. Right? ठीक है. Air powder abrasion technique is basically air polishing. So there is air abrasion, which you do with alumina in the size of 25 to 30 micron alumina. Then there is air polishing. What is that? That is basically polishing the tooth once you've done your scaling. So in that you use a slurry of water and sodium bicarbonate. So the answer here is sodium bicarbonate. In vital pulp therapy, simple question. Vital pulp therapy, surgical removal of 2 to 3 mm is Schweck pulpotomy or partial pulpotomy? So the answer here is partial pulpotomy. The other options were totally confusing, trying to confuse us, made no sense. Partial pulpotomy is the answer, right? Surgical removal of 2 to 3 mm of the corneal pulp, which is not minimally invasive dental procedure. Simple, guys, pulpotomy, right? What is ART? Silver modified ART, atraumatic restorative treatment, minimally invasive. Both. Hall technique is what? In pediatric dentistry, there was this one person who said that whatever the size of the carious lesion, do not restore it, make stainless steel crowns without touching the tooth. Just make stainless steel crowns and adapt them and lute them. So that's again minimally invasive. So pulpotomy is relatively more invasive. So that is not a minimally invasive technique. Which is the lightest shade? I always tell this, B1. B1 lightest, that is whitest, and C4 darkest, right? So B1 is the answer. Lightest shade in beta ठीक है, नहीं बेटा पार्शियल पल्पेक्टमी नहीं था, विच इज नॉट मिनिमली इन्वेसिव, ये वाला कह रहे हो, पल्पोटमी था। B1, ठीक है। Okay, yes. Then there was an image-based question in which you had this Ellis class 3 fracture, right? They asked us about the initiation of the pathophysiologic process which would lead to apical periodontitis. And the options were pulpal exposure, pulpal necrosis, acute pulpitis, and apical periodontitis. What is the start? How do you initiate the pathophysiology of eventually apical periodontitis happening because of the pulpal exposure? So the answer is pulpal exposure. This is a continuum, right? First pulp exposure will take place. You won't treat it. Acute pulpitis will take place. You won't treat it. Pulpal necrosis will take place. You won't treat it. Apical periodontitis will take place. But what is the pathophysiologic initiation of that entire process which would lead to apical periodontitis? Pulpal exposure. Yes, beta. 37 कौन सा कह रहे हो? हाँ, in VPT surgical removal of 2 to 3 mm. इसका आंसर partial pulpotomy है बेटा. And this option was there. Rest were totally wrong. Superficial, miniature, it's not making any sense. Partial pulpotomy is the answer, right? Then, okay. Then there was an image-based question in which you had this device, right? Is it intraoral scanning? Is it laboratory scanning? No, it was a clinical image. There was a patient's mouth. It was not a cast that was poured. Light curing or laser therapy. This is intraoral scanning. This is a 3D scanner. And the question was that light was emitted in a pulsed mode. It was an image-based question. What is this? The answer is intraoral scanning. Right, guys? Acha, okay. Just share the version of this question, whatever you think. Order में क्या, what the pathophysiologic process, है ना? If I remember correctly, beta, it's the pathophysiologic process. Where does it start? Which leads to apical periodontitis. Pulp exposure, pulp necrosis, acute pulpitis, apical periodontitis. That was the question. If not, then please just mention whatever you think is the question in entirety. I think this is the question, right? Pathophysiology. हाँ, pathophysiology का order था. Okay, then it's simple, guys. Pulp exposure, acute pulpitis. Then it's very simple. Pulp exposure, acute pulpitis, pulpal necrosis, and apical periodontitis, right? बेटा नेक्रोसिस पहले नहीं होगा ना? हाँ, ठीक है. If order, then it's very easy, dear. If order was asked, then it's very easy. Pulp exposure, acute pulpitis. Acute pulpitis is an old term for symptomatic irreversible pulpitis. वो पहले वो होगा ना, तभी तो necrosis होगा. Then pulp necrosis, then apical periodontitis. Is that fine, all of you? Yes. 30 gauge needle, which is a side vented closed end, is not beveled. It's round. All right. Then, okay, guys, one more question. For tissue retraction during full crown, what all can you use? You can use all the four. You can use electrosurgery. You can use for tissue retraction, gingival tissue retraction. For gingival tissue retraction during the impression for full crown. What do you use? Displacement cord, displacement, I think solution or liquid, that is also there, like Expasil. The example is Expasil, right? You can just inject this in the gingival sulcus and it opens up. then electro surgery or cautery, whatever, and you have laser. So all these can be used. All are correct. Displacement paste, yes. It's not solution, it's a paste. Exactly. Wonderful. Right, guys? Okay, all can be used. Was this a question in which multiple combinations were there? A, B, C, D, A, B, C, B, C. Was this the question? Yes? बताओ निकेश, यही था ना? There were different options, right? So all can be used. Great. Very good. Chalo guys, so I think now you realize the question paper was tricky. Apparently easy but tricky, but that's how these days the examiners are. In fact, what high level of questions they do give, right? They try to confuse us. All of them was correct. What, Mohit, you did all of them correct? Wow. Expect a good rank, dear. I wish you all the very best, guys. Now just relax and keep up the motivation, keep your spirit high. And yeah, let's all just keep working hard and keep praying hard, right? Chalo, good. I'll see you around, guys. Thank you.